Hello everyone, we'll get started with this oral session on image generation. So I'm Carol Sud from King's College London, and with Matthias Heinrich from University of Lübeck, we'll be chairing this session. Before we start, just to help you with questions, so you have on the webinar a Q&A button on which you can basically ask your question during the talk so that actually the author afterwards can properly answer them. So we encourage you to write your questions there during the presentations. And so we'll start with Chen Peng from University of Maryland that will talk to us about his work towards multi-sequence MR image recovery from undersampled case-based data.
Welcome to our presentation on towards multi-sequence MR image recovery from undersampled case-based data. Our work focuses on speedy recovery of multiple undersampled MR sequences. My name is Chang. I am a first-year PhD student at the University of Maryland, advised by Professor Ramachalapa. Recovering MR sequences from undersampled data has been of significant research interest as they can accelerate MR acquisitions. Traditionally, MR machines acquire signals in the K-space and perform inverse Fourier transforms to convert the signal to the image space. Such an acquisition is a time-consuming process, which limits the availability of MR machines and may be prone to motion artifacts. Ideally, we like to sample only part of the K-space and recover the degraded information through algorithms to speed up acquisition. It's worth noting that for the purpose of this work, we consider recovery as a post-processing step after all the case-based acquisition is done. To give some more background, there are many factors that influence MR acquisition time. The relevant ones for us include the sampling trajectory, the sampling resolution, and the number of sampling sequences. Sampling trajectory determines the pattern of which case-based data is acquired. Sampling resolution determines how many points on the K-space are measured, and sampling sequences are used to highlight specific regions or materials, for instance, for fluid or tumors, which are useful for diagnostic purposes. Generally speaking, the most widely used sampling trajectory is Cartesian sampling, and the most convenient way to undersample is by reducing measurements in the phase encoding dimension. The undersampled case-based signals generate low-quality MR images. Recent works focus on recovering single sequences from degraded acquisitions by using convolutional neural networks. There are also some works that attempt to complete the case-space with varying success. In our work, we are interested in the scenario where multiple sequences need to be taken in one session. This provides an advantage where we can exploit the highly correlated information across different sequences, assuming that they're taken in one scanning session and that the patient maintains a relatively stable position during the scan so that the pixels are relatively aligned. Under this scenario, we like to answer the question of how much does the shared information help multi-sequence reconstruction and what's the best undersampling strategy, while accounting for factors like different acquisition time for different sequences. And we use standard metrics like PSNR and SSIM to measure performance of recovery. To give a concrete example, let's look at two sequences, T1 and T2 flare, of the same patient. We can observe that the two sequences contain very similar information. In fact, most of the information observed in T1 can also be observed in flare. However, the reverse may not be true. For instance, the tumor is not very visible in T1. On the other hand, T2 flare takes a lot longer to be acquired than T1, so it is not immediately clear how to obtain the best undersampling strategy. And that's an important piece of information because we can optimize performance better with a specific undersampling strategy as opposed to optimize for all potential or all possible strategies. And the essence of our work is to provide an algorithm to find such a strategy. To begin with our exploration, we need to set up a standard CNN model for all of our experiments to keep everything fair. In our case, we employ the residual dense network, or RDN, as the basis for our network structure. This model architecture has been shown to perform better than UNet-based architectures in tasks like super resolution and denoising. We modify RDN to fit our use, to simultaneously take multiple undersample sequences as input and output multiple recovery sequences. So what are some of the ways that can be used to find a good undersampling strategy? So there are some obvious choices. Firstly, we can use the same undersampling strategy for every single sequence. It's relatively intuitively clear that this may not be the best approach, given that the time cost is different for every sequence, and that it is harder to explore the shared information between sequences when they are similarly degraded. Secondly, we can employ a brute force method by training a network for every possible undersampling strategy and choose the best performing one to use. However, this is expensive and infeasible. We can also directly measure the PSNR of sequences degraded by different undersampling strategies and choose the strategy that yields the best PSNR. The advantage here is that we don't need to train any model. This approach, however, comes with the issue that PSNR doesn't always measure the information presented in the sequences accurately. So an example would be aliasing, which may be produced by undersampling the k-space slightly, but affects PSNR disproportionately more. Some degree of aliasing can be pretty well corrected by CNNs. So this direct measurement approach potentially causes some good undersampling strategies to be overlooked. Another example is that we can have a combination of extremely undersampled sequences and highly sampled sequences, which may lead to an overall lower PSNR. However, CNNs can learn to leverage the similarities between different sequences and reconstruct the severely undersampled sequences pretty well. So this also creates a case where the direct measurement approach can miss out on good undersampling strategies. Instead of measuring the PSNRs of degraded MR sequences directly, which suffers from inaccuracies in measuring the impact of certain artifacts and the correlated information between sequences, we propose to train a CNN network to recover sequences that are degraded in various degrees, and then measure the PSNR of the recovered sequences. We call such a network a blind recovery model, or BRM, which is optimized for recovery over L1 or L2 constraints. The key point here is that BRM does not recover sequences optimally for any particular undersampling strategy because it has to accommodate for all of them. However, we can use a BRM that is trained to optimize the PSNR metric as a way to account for factors that were hard to be measured directly on degraded sequences. To elaborate on the details, given a set of available sequences, their respective sampling time, and assuming for Cartesian sampling, we can express all possible undersampling strategies with a simplex under a particular time constraint Tmax. At each iteration during training, we can select a random strategy from all possibilities and use it to generate the corresponding undersampled sequences, which then are fed to BRM for training. For this work, we use two datasets for experiments, one of which is a privately collected multi-sequence dataset containing raw k-space data for T1, T2, and T2 flare. 20 patients participated and overall produced close to 3,000 pair images. To expand and test our idea on larger datasets, we selected 167 scans from the BRATS dataset, which are co-registered in T1, T2, and T2 flare. We then simulated their k-space data. We like to know that the simulated k-space data is somewhat different from real data, such as the fact that the simulated k-space would be conjugate symmetric. This can lead to some discrepancies in terms of performance for real data. The results are visualized in this graph. In the graph on the left, we observe two things. First is that simultaneously recovering multiple sequences together, labeled as MIML, performs much better than recovering sequences individually, which is labeled as SISO. Secondly, the PSNR of the recovered sequences is generally well correlated with that of the degraded inputs, which is indicated by the red line. However, this is not always the case in regions. To know whether a particular strategy performs best when a CNN optimized solely on that strategy, we need to train dedicated models for all strategies and then compare. While that is clearly infeasible to do for all strategies, we can do so for a selected number of them to show local performance. In our experiment, we selected a region where the PSNR of the degraded inputs and the BRM outputs do not correlate well, such as the one circled in blue. We then train a dedicated recovery model for every undersampling strategy in that region to observe which approach correlates better to the dedicated model performance. We find that, as shown in the graph on the right, the PSNR performance of dedicated models, which is the green line, is highly correlated with that of the blind recovery model, and in fact negatively correlated with the PSNR of the degraded inputs. This agrees with our hypothesis that PRM can indeed be used as a better guide to select good undersampling strategies. Once we use BRM to find the undersampling strategy, we can fine-tune the strategy very quickly based on the trained BRM to achieve performance similar to that from dedicated models. The entire pipeline is shown in this graph. Now, we show some visual results here on the recovered image quality under different training settings. Based on our real data sets, we find that the undersampling strategy is to distribute most of the sampling to the T2 sequence. This is under the assumption that all sequences take the same amount of time to acquire. We find that to be intuitively reasonable, as T2 provides the best contrast on details. The details can then be shared to recover other sequences. We can change the presumed sequence-specific time costs by adjusting the variables in the simplex formulation in slide 12 and obtain all possible undersampling strategies under a different setting. Here, the time costs are just to such that flare takes much longer to acquire than T2, which takes much longer to acquire than T1. This is more closely related to real scanning conditions. In this case, we find that the best sampling strategy is still to sample T2 the most of all three sequences. However, T2 is sampled less compared to when sequences have the same time costs, and the leftover sampling portion is used to sample T1 more, as T1 can be more quickly acquired. This is consistent with our expectation, as ideally the sampling strategy should maximize the total energy sampled in the K-space, as Parselow's theorem would indicate. In this table, we list some more quantitative results for the top performing undersampling strategies. An interesting thing to observe is that for a scenario of equal acquisition time costs, for real data, the top sampling or undersampling strategies flip-flop between sampling T1 or T2 flare more, indicating that they are of similar importance for recovery. However, on simulated data, flare is consistently sampled more than T1. This is most likely due to the different distributions between datasets, as Brad's dataset investigates brain tumors, and tumors have much better contrast on flare than on T1. The real dataset is collected on healthy subjects, therefore implying that flare will less often contain unique information. In conclusion, we proposed a learning-based method to address the multi-sequence recovery problem. Specifically, we leverage a RDM-based network to solve for such a recovery problem in a data-driven way, and introduce an efficient algorithm to determine the best undersampling strategy for acquiring multiple sequences. We show with empirical evidence that our algorithm produces an undersampling strategy that is highly correlated with the ideal one, as indicated by performance from dedicated models, while not having to exhaustively train dedicated models for every possibility. This makes the search problem computationally feasible. We show that the found sampling strategies are generally consistent with mathematical constraints and our intuition. With that in mind, we'd like to thank the audience for their interest and time in listening to this presentation. We appreciate any advice or suggestions on our work. Thank you.
Thank you very much. I don't know if that. So if you have any question, please put them on the Q&A so that we can ask them directly. And while waiting for some people to manifest themselves here, I will start with one question. When actually you say that you are sampling at, you are optimizing the undersampling across the 3 sequences that you are looking at, have you checked if the PSNR or the SSIMs that you obtain on each individual sequence is relatively similar, or do you observe a strong drop in the sequences that you undersample more?
Yeah, so it depends on the specific undersampling strategy. Obviously, the more undersample, let's say a specific sequence is, the more, like, generally speaking, the more increase we observe. But then at the end, it will probably still be a bit lower than the other well sampled sequences.
And especially because it's a flare, and afterwards it's a lot used for any lesion type analysis. You don't have any issue of further processing?
I'm sorry, the last part is the issue with what?
So if you want afterwards to use mostly a flare image because it covers a lot of the lesion type and pathology information, and if
Right.
it's one that naturally you undersample more, do you have issues with further post-processing?
So issue with further post-processing. Okay, so I think the concept of it is that let's say if there's a specific sequence that's very important, let's say flare, right? Because flare covers tumors and a lot of essentially diagnostically important, then I think in practice, doctors or practitioners would like to sample that more, and then we can adjust the other ones, because ultimately in a sort of data-driven way, I would say that in practice, it will be more confident for a diagnostic purpose, or for post-processing, like lesion detection purpose, if it's more sampled, because that's the real observation.
Okay, thank you. So we have a few more questions from the audience. So Hans Meyer was asking if you could elaborate on the requirement for the subject to be relatively stably positioned with respect to problem with motion.
Right. Okay. So that's the requirement is I would say somewhat. Well, I mean, obviously it's necessary, but it's not like a super strict requirement. In that if a patient sits in the scanner, then we can expect that they don't move wildly, and then we can also correct motion or do some registration process that aligns the scan. So the requirement, yeah, I mean, and that's what I would say to that.
Okay, just one last question before we move to the next talk. Emmanuel is asking how you think the radial subsampling would influence the results.
We have not tested that. I would expect it to be a bit more complicated because radial sampling will require a a more nuanced reconstruction method, other than just the straightforward inverse Fourier transform. So then the relationship is maybe not as clear. Yeah.
I think we are already past time. The 20 minutes are gone. So I would ask the one who still have some question about that talk to maybe ask them during the poster presentation afterwards. And so we'll move to the second talk presented by Sri Prabha Ramanarayan from Indian Institute of Technology of Madras, and the title of the talk is Recon, a multiple acquisition context-based convolutional neural network for MR image reconstruction using dynamic weight prediction.
Welcome to the talk on Recon, a multiple acquisition context-based convolutional neural network for magnetic resonance image reconstruction using dynamic weight prediction. I am R. Sri Prabha from Healthcare Technology Innovation Center, Indian Institute of Technology, Madras, India. Magnetic resonance imaging is a non-invasive modality well known for providing good soft tissue contrast. The reconstruction of fully sampled images from undersampled measurements to accelerate acquisition plays a critical role in MR imaging. Methods based on compressed sensing have been deployed in clinical environments, however involve repeated parameter tweaking and iterative computations, leading to long reconstruction time. Recently, deep learning-based algorithms have shown to provide faster and good quality MR image reconstruction. The fundamental challenge in translating these methods to an MRI workstation in a clinical setting is that these methods heavily depend on training data in learning the mapping from undersampled images to fully sampled target images. They suffer from a covariate shift in data distribution, wherein a model trained using images from a particular distribution tends to perform poorly on data from a different distribution. So can we address this fundamental challenge is the question now. We introduce a few terms here so as to proceed. Typically, the model is trained with images from particular setting. So different sets of weights of convolutional neural networks are learned for training data with different input settings. We consider three such settings specific to MRI, namely anatomy under study, the acceleration factor for undersampling, and the undersampling mask pattern. The typical values of acceleration factors can be 2x, 5x, and so on. The undersampling pattern and anatomy under study are shown. We call any combination of one or more of these settings as acquisition context. Context-specific model or CSM is a model that is trained on a particular setting, that is a particular acquisition context. The model is evaluated with the same context. For instance, we could have a CSM on cardiac images, Gaussian undersampling, and 5x acceleration. A joint context model is a model trained using a large corpus of images obtained from various contexts. Unseen context is an acquisition context with which the model is evaluated and is not known by the network at train time. For instance, we could train the model on cardiac images with 4x acceleration, and we test the images with 4.5x acceleration. Using these terms, we come back to our problem of flexibility of CNNs for MR reconstruction across contexts. The context-specific models, as the name says, are experts in their own context. They provide good accuracy when evaluated because they are already overfit to their context. CSMs must be trained separately for each acquisition context. For instance, 2 anatomical studies, 5 acceleration factors, and 2 undersampling patterns would generate 20 training contexts. When the number of contexts increase, the combinations also increase, and the CSMs to be stored grows large, putting a practical limitation. Hence, they are not efficient in terms of storage. They cannot perform well on unseen contexts also due to covariate shift. And yes, separate model for each context, that is task-specific weights are obtained. On the other extreme, we have joint context model wherein images from as many contexts as possible are taken and the model is trained. For instance, we could create a large entity of training data from multiple contexts and train the model once. For Bayesian, the accuracy is not as good as the CSM, but they are memory efficient. because one common weight set is being learned for all the contexts that we consider. JCMs do not perform well in unseen contexts, and no task-specific weights are obtained. In our work, we show that the proposed method inherits the benefits of both CSM and JCM. So how do we bring in this flexibility? By making the network aware of the acquisition context of each training image, and by feeding the context information to the network along with the respective images. How do we do this? We define a context vector as a numerically encoded vector to represent an acquisition context. For example, it could take 3 entries indicating acceleration factors, study, the pattern, and so on. We use the auxiliary network that learns to map the context vector with the respective input target pair. This network is called the dynamic weight prediction network. The core idea of dynamic weight prediction is that instead of directly learning the model parameters of a base reconstruction network, another network can be used to predict the weights of the base networks to effectively handle multiple contexts. Advantage: we get different set of weights for different contexts and better accuracy. The model is storage efficient and is generalized across unseen contexts also. We summarize our contribution as we propose a multiple acquisition context-based network for MR reconstruction called the Recon net, consisting of a reconstruction module and a dynamic weight prediction module. The reconstruction module performs undersample MRA reconstruction. The dynamic weight prediction module takes context vector as input and learns context-specific weights of the reconstruction module dynamically. We show that the proposed approach can handle multiple contexts involving input settings that we considered in our discussion so far. And we also consider 3 clinically relevant contexts and show that the proposed network outperforms JCMs and give competitive results with the context-specific models, both quantitatively and qualitatively. So, in the problem formulation, a CNN-based MRA reconstruction can be formulated as an optimization problem as shown. In this, the first term enforces the desired image X to be well approximated by a CNN reconstruction. The CNN reconstruction XCNN is equal to CNN of XQ parameterized by WCNN, where WCNN is the network weight. And the second term enforces data fidelity in the case space to ensure consistency with the acquired case space measurement. We note here that the acquisition context is mapped to the CNN weight by the DWT function highlighted in green here. In our case, it's a neural network which learns this mapping. So the architecture of MAC is cascaded architecture. The top left figure shows the overall block diagram of the architecture. The reconstruction module at the bottom is a cascade of NC CNN blocks with residual connections and case space data fidelity units in an alternating manner. And there are NC DWP blocks, and each DWP block learns the weights of the respective CNN. Top right shows 1 unit of DWP and CNN in the cascade, and each CNN has 5 convolution layers with nonlinear activations. The formulation of the cascaded unit and the dynamic weight prediction network is shown at the bottom. So during training, the loss calculated between the predicted reconstructed image and the fully sampled target image is back propagated to learn the weights of the DWP block. And the weights of the MRA reconstruction network are not made learnable. As a result, the weight of the DWP module are based on not only on the context vector but also on the image domain loss. At test time, the context-specific weights for the CNN are generated by multiplying the learned weights of the DWP with the context vector and adding the bias values of the DWP. So we consider 2 data sets in our experiment: the cardiac ACDC segmentation challenge dataset and the MR brain T1 and FLAIR images. And we use L1 loss function for training. And we consider 3 contexts relevant to clinical scenarios, which we will be seeing in detail. In the first study, we keep the anatomical study fixed and we vary the undersampling pattern and the acceleration factor. This context is flexible to scenarios wherein Cartesian undersampling which is practical to implement and simple to reconstruct, is preferred, and other kinds of undersampling like Gaussian, spiral, where higher accuracy metrics are preferred. The context vector has two elements. One dimension is the acceleration factor, and along the other dimension we have the undersampling mask pattern. There are 5 factors, acceleration factors, and 2 patterns, and this amounts to 10 context-specific models, which we have used for comparison here. And for JCM, we take all the images of these contexts and train the reconstruction network alone. We see that the metrics are closer to that of the CSM, and the reconstructed images are qualitatively closer to the target. And this is indicated with the residual images at the right side with reduction in the error. In the second experiment, we fix the undersampling pattern and we vary the acceleration factor and the anatomy under study. In this context, demonstrate the flexibility of our model for scenarios like multi-contrast MRI, wherein multiple sequences like T1, T2, proton density weighted MRI of the same anatomy are acquired for diagnosis. So we see that in this case also the metrics are closer to the CSM and much better than the JCM. In the qualitative analysis, we see that in the highlighted regions and regions marked with arrows, the improvement as far as recovery of details is better. So yet another experiment is the unseen case, the one in which the context is unseen at train time. So in this, we fix the anatomy under study, and we also fix the undersampling mask pattern, and we vary only the acceleration factor. We choose 5 specific acceleration factors for training, and while testing, we take 28 unseen contexts. So from 2.4 to 7.6, we vary in increments of 2. This generates 28 unseen contexts, and 26 out of 28 have shown improvements over the joint context model, and the performance were equivalent to that of the CSM. And for comparison, we have taken 7 CSMs and then we have tabulated, and the respective JCM is also shown. And the table shows that the proposed method shows improvement over the joint context model, and equivalent performance to that of the CSM is obtained. The same is noticed in the qualitative analysis also, and we have taken here, we have shown the 7.6 unseen context case. And in the box plots that we see, we have taken 14 unseen contexts and we have plotted the PSNR and SSIM improvements over the joint context model. So in all these contexts, in all these experiments, we have seen consistent improvement over the joint context model and equivalent performance to that of the CSM. And in the conclusion, we see that a CNN-based MR reconstruction that exhibits flexibility to multiple acceleration contexts could be more appropriate for a clinical scenario. And the proposed Recon net incorporates this flexibility to multiple contexts in a single model by using a dynamic weight prediction module to generate context-specific weights for MR reconstruction models. We are currently working for a journal extension of this work towards improving the architecture to suit more clinical scenarios and extend the model to complex and parallel MRI datasets and many more experiments to come. Thank you.
Thank you very much. As before, I invite all the people who have questions to put them on the Q&A. As nobody has put anyone before, I will start again with one while waiting. I was wondering actually when listening at your presentation, how the weights of the DPW were changing when you had actually different or unseen context, and if you had some that were dropping to 0, for instance. Sri Prabha, you are muted. Yeah.
Am I audible?
Yeah, you can. We can hear you now.
Yeah. Could you repeat your question? You said 0.
I was wondering how the weights of the DPW were changing when you had unseen context, and if you had some that were dropping to 0 in certain circumstances.
The context vector, when the context vector drops to 0, is that your question?
Weights of 0 in the DPW when you learn them.
For the unseen context, we fixed other parameters and we just changed only the acceleration factor. So in the context vector, we passed a single parameter and we tried to understand if the network is able to actually interpolate between two known attributes. So for instance, if you train the network with, let's say, 3 acceleration factors, say, let's say 4, 5, and 8. And you set up a scenario where you want to test images with acceleration factors 6 or 7. So under such circumstances, the network is able to interpolate between these known attributes linearly, and then is able to generate the weights for 6x and 7x. And the performance of 6x and 7x are closer to the performance that we would get if we train the model separately for 6x and separately for 7x. Those are the context specific models. So this network has this capability of interpolating between known attributes. So when we go for higher dimensional context vectors, for instance, so this will be definitely useful because now we have taken only 3 dimensional context vectors. But there may be in MRI workflow, we have several such DICOM attributes to consider. And at the time of deployment, in the overall workflow, we would need this flexibility where you will not have, you will have several such unseen cases and still would not have been addressed at the train time. And at that time, this strategy should help. That is the idea.
Thank you.
Since there's still no questions on the public chat, I will ask a second one from us. Your dynamic weight prediction network is, I think, quite a unique setting in CNNs for image reconstruction, but your architecture in which you're predicting the weights dynamically doesn't seem to have any normalization layers. So did you experience any problems in the scale of the weights that are predicted for different layers in the depth of the network?
We have included a batch norm. A batch norm is included in the layer before the convolution happens. In fact, yes, in this block diagram it is not there, but it is presumed that a convolution with batch normalization is happening actually.
And do you predict batch norm weights as well?
No, we are more interested on the CNN weights, which influence more on the reconstruction part.
Okay, so in general, you found that the architecture used to predict weights isn't too sensible towards your results, or did you experiment a lot with this?
Pardon me, could you repeat?
Whether the architecture you use in the dynamic weight prediction block is very sensitive to your results, or is that like something that's often like reasonably trained well in with many different choices of hyperparameters?
We didn't change the hyperparameter settings. For example, we have fixed the hyperparameter settings that we had for context specific models and for our model. So, and then we vary only the context vector, and the training data is also same. So when you compare 1-to-1, see the joint context model will have those, let's say 1,000 images. You train the images in a single network, and it has all acceleration factors, let's say. And you take the same 1,000 images, and in addition to that, provide one more information called the context vector and train our network, the proposed network. So definitely when we change the context vector and image pair, the weights will change. So that is what we have shown in the third experiment for the unseen case, that the weights are definitely sensitive to both the image and the context vector. So that is somewhere which we are still working on that, and then we're trying to understand that more for many workflow needs of the MRI.
So thank you very much. I think this was a very good answer, and we can move on to the third talk in this session, which is a heteroscedastic uncertainty model for decoupling sources of MRI image quality, and was submitted by Richard Shaw and others from KCL.
Hello, my name is Richard Shaw, and I will be presenting our work on a heteroscedastic uncertainty model for decoupling sources of MRI image quality. I will first talk about the context and motivation behind this work, specifically MRI artifacts, quality control, and the different types of uncertainty that we can model. I will then explain our proposed methodology and how we can predict uncertainty for the task of segmentation. I will explain how we propose to decouple sources of uncertainty relating to different image quality issues using a decoupled uncertainty model. I will walk through our network design, training strategy, and our case-based augmentation models. Then I will show some of our results from experiments we have done on both simulated and real-world artifact data. Finally, I will sum up by discussing the current limitations of our model and our plans for future research. Artifacts in MRI can cause image quality to degrade and can affect downstream analysis, such as segmentation predictions and biomarker measurements. Common artifacts include patient movement, acquisition noise, blurring, aliasing or wraparound artifacts, radio frequency spikes, and many more. In MRI, there are a large variety of potential artifacts that need to be identified so that problematic images can either be excluded or accounted for any further image processing and analysis. Quality control, or QC, is the process of establishing whether a scan or dataset meets a required set of standards and is necessary to ensure that the data is of sufficient quality to perform a particular task. However, fully automated quality control remains an unsolved problem, and currently QC is predominantly performed manually at significant time and operator cost. It is also subjective, protocol dependent, and subject to inconsistencies between raters. The gold standard for QC, however, remains manual visual inspection of images by trained analysts. Automating this process would be especially useful, given the current trend in deep learning towards acquiring and exploiting larger and larger imaging datasets, such that the time and resources required to perform manual QC is becoming prohibitive. Indeed, current automated methods of QC are rather limited, and the lack of real-world artifact data with corresponding QC labels makes this a challenge. QC is also dependent on how we define image quality. For instance, consider these two T1 weighted scans from the ADNI database. Both of these images have failed manual QC and have been judged unusable by expert raters for containing motion artifacts. However, in the image on the right, the artifact does not intersect with the brain, and therefore would actually be a usable image for a brain segmentation task. Thus, there is a clear distinction between what a human defines as acceptable scan quality and the quality that is required for further algorithmic processing. Therefore, we can define quality from a task point of view. Since image quality hampers our ability to reach a conclusion, this can be represented by the uncertainty of making a prediction. We propose to use Bayesian neural networks to measure image quality as a task uncertainty prediction. In Bayesian deep learning, two main types of uncertainty are commonly distinguished: epistemic uncertainty and aleatoric uncertainty. Epistemic uncertainty is the uncertainty in the model, and aleatoric uncertainty depends on noise or randomness in the data. The aleatoric uncertainty is further divided into the homoscedastic component, which is the uncertainty of the task, and the heteroscedastic component, which is the uncertainty due to the data. As we are interested in how data quality affects our predictions, we adopt a heteroscedastic uncertainty model, as this provides a natural way of modeling the quality of the data. For segmentation, we can model the task as a voxel-wise classification problem, where the output logits of a neural network f of x are scaled by a variance and squashed through a softmax function to give a probability that a voxel belongs to a particular class. Maximizing the log likelihood of this expression results in the loss function shown here, which we can use to train a probabilistic segmentation network. The network will have two outputs, a segmentation prediction f of x and a total uncertainty sigma squared. Note that the uncertainty as measured by the predictive variance is learned from the data in an unsupervised manner. In order to use the predictive uncertainty as a measure of image quality, we must determine how much of the total uncertainty is the result of artifacts or image quality issues affecting the segmentation. Therefore, we propose a model to decouple the total predictive uncertainty into separate quantities relating to the task and to different kinds of imaging artifacts. We make the assumption that the sources of uncertainty affecting an image are independent, for instance noise due to the receiver coils and artifacts due to patient movement within the scanner. Following this assumption of independence, the total predictive variance can be simply decomposed as the sum of variances of independent events. Specifically, we decompose the total variance into the sum of the task variance, sigma t, which is the uncertainty of the task when given clean data, and the augmentation variances, sigma I, for n possible artifact augmentations. Note that this is not strictly true because interactions with task uncertainty and between degradation types exist, but modeling this would require the learning of additional covariance terms and would greatly complexify both the model and the training procedure. However, this is an important assumption of our model to make the problem tractable. So if we take our original Bayesian loss function and substitute in for the total variance, we arrive at the loss functions shown here. The first loss function, which is unchanged, we refer to as the task loss, as this learns the task uncertainty when provided with clean data. The second loss we refer to as the augmentation loss. When given artifacted images, the network learns both the task uncertainty and the uncertainty sigma I due to that specific artifact or augmentation. The final loss is a combined loss function, which attempts to learn all possible augmentation and task uncertainties. Since uncertainty is learned in an unsupervised way, to be able to learn these decoupled uncertainties, we introduce a novel training scheme using a cascading student-teacher network architecture. Since we do not have labels of uncertainty maps, we use a sequence of CNNs to learn pseudo-labels of uncertainty maps related to each image augmentation we wish to decouple. These pseudo-labels are then used to self-supervise each subsequent network using an additional consistency loss. The training procedure is as follows. First, we train the task network on only clean images to predict the segmentation Y and a single task uncertainty quantity. We then freeze this network, and for each augmentation we wish to decouple, we train an additional augmentation network. The network predicts two uncertainties, the task uncertainty again, and the IF augmentation certainty corresponding to the artifacts seen by that network. A consistency loss is added between the task uncertainty from the task network and the augmentation network, so that the network is able to decouple the task uncertainty from the augmentation uncertainty. Once we have trained all augmentation networks in turn, we freeze all previous teacher networks and train a combined student network to predict all decoupled uncertainty quantities. Each augmentation uncertainty is supervised by its corresponding augmentation network using the same consistency loss. This results in a single network that is able to predict the segmentation given the quality of the data and all decoupled uncertainty values. The consistency loss we use is the voxel-wise L1 loss over the uncertainty predictions, plus the L1 loss over the gradients and a 3D structural similarity term. The loss was empirically derived as we found it gave better results than a simple L1 or L2 over the uncertainty predictions. However, in the future, we would like to explore different loss functions and do a full hyperparameter search for the best configuration. The gradients and structural similarity losses help preserve the structure of the uncertainty maps as the level of input image quality reduces. Since the uncertainty is learned from the data, to predict the uncertainty corresponding to different MRI artifacts, we augment our training data with simulated case-based augmentations, including Rischian noise, image blurring, wraparound, aliasing artifacts, radio frequency spikes, and motion artifacts. All augmentations are performed by computing the 3D Fourier transform of the input image volume, modifying the case space in a randomized way before transforming back to the image domain and taking the magnitude image scaled between 0 and 1 as input to the network. RF spike artifact is characterized by dark stripes over the image caused by the convolution of spikes in case space of very high or low intensity during the Fourier transform. To model this, we sample uniformly the spike location in case space, which defines the angle and frequency of the stripes, and its magnitude, which defines their intensity. Noise augmentation involves injecting Gaussian noise into the case space to model Rischian noise in the image domain. We randomly sample the signal-to-noise ratio of the image uniformly, and the corresponding amount of complex noise is added to the case space. Blurring artifact can be observed when acquiring data at a lower resolution prior to resampling. We apply a low-pass filter by truncating the case space to simulate this effect. Aliasing or wraparound artifact occurs when the imaging field of view is smaller than the anatomy being imaged. We retrospectively simulate this by masking out case space lines along a random axis that defines the wraparound direction. To simulate patient movement artifacts, we resample the input image volume using a random sequence of affine transformations and combine their respective Fourier transforms to generate a case space containing motion. For more information on how we generate motion artifacts, please refer to our paper below. All the networks in our model use the 3D UNet as their base architecture, where the output of each CNN is modified with two output heads, one for the segmentation prediction and one for the uncertainty. Each uncertainty output has a different number of channels depending on the number of uncertainties we wish to decouple. For training data, we use scans from the ADNI database. We use 272 scans that were deemed to be artifact-free, split into 80% training, 10% validation, and 10% testing. We apply artifacts at a rate of 0.5 so that each augmentation network sees roughly 50% clean images and 50% artifacted images, allowing each network to learn both the task uncertainty and the artifact uncertainty. Now we show some results on simulated data. A model trained with simulated artifact augmentation was used to perform inference on the holdout test images. In this figure, we have corrupted the test set with spatially varying artifacts to show that our model is able to localize and highlight the artifacted regions. The input images are shown on the top row. The second row shows the network's segmentation predictions. The third row shows the predicted task uncertainty, and the bottom row shows the corresponding augmentation uncertainty. Looking at the augmentation uncertainty, we see that areas of high uncertainty are generally found in the artifacted regions. Note that in the case of very heavy noise, the task uncertainty decreases as the signal is impaired, and therefore the model reverts back to its prior distribution. In this figure, we show a selection of results on real-world images containing artifacts. Given that the model was trained only on simulated data, the results show that the model is able to somewhat generalize to real-world artifacts, correctly identifying the artifacted areas affecting the image. There are a number of limitations with the current model. Firstly, the model assumes that the input data to the network is completely free from artifacts to begin with. However, due to the subjective nature of QC, many images that pass QC can still contain minor artifacts, and it is quite difficult to ensure that this will always be the case. Secondly, as we assume sources of uncertainty are independent, to make the problem tractable, we are not able to model complex interactions between sources of uncertainty. For instance, noise and blurriness artifacts will clearly interact with each other. Additionally, the model's ability to decouple task and augmentation uncertainties is dependent on a number of factors, including model size, network capacity, the appearance variability of the artifacts, and the severity of image degradation caused by these artifacts. Clearly, the more severe the artifact, then the harder it will be for the model to decouple the task uncertainty from the artifact uncertainty. The amount to which the model can decouple uncertainties is an aspect we would like to explore in future research. In summary, we have proposed that MRI quality can be estimated from the uncertainty in performing a particular task, such as image segmentation. We have presented a method for estimating task-specific image quality using uncertainty predictions, and we have shown that we can approximately decouple sources of uncertainty to localize artifacted regions in MR images. We hope this will lead to a real-time quality control warning system for clinicians and radiologists. For our ongoing research, we are in the process of gathering more real-world data with QC ratings and comments to perform more extensive quantitative validation of the network's uncertainty predictions when presented with real-world artifacts. We are also investigating the disparity between human perceived visual quality and the algorithmic quality of a task using a multitask network. This network models visual quality as the uncertainty of an image reconstruction task. Further experiments are being performed to investigate the generalizability of different case-based artifacts, and also to explore the network's ability to decouple uncertainty under different severities of artifact augmentation. Thank you for listening, and please refer to our paper for more details.
Thank you very much, Richard, for this nice presentation. There is just one question on the Q&A so far by Kaihan. He asks whether you inspected that your model associates high uncertainty with normal-looking images, if there is any pattern to it. So, for example, if there are flags in normal-looking images, mainly on old patients, patient tumors. So if you're kind of, there's a chance that introducing biases in that direction.
Yeah, I mean, I don't quite understand the question. So normal looking images, I mean, the big, because our model decouples uncertainty, the normal looking images shouldn't have any artifact uncertainty, and all the uncertainty should be related to the task. But I think our images can contain tumors.
Yeah, I think the question is whether this kind of your model might be interpreting pathologies as artifacts. I hope I understood Kaihan's question correctly.
Right, yeah. So we haven't really looked at that. Because we treat augmentation as like an additive process, and we consider our input data as clean. I don't think the tumors will be treated as uncertainty due to artifacts. That uncertainty will be like incorporated into the task uncertainty. So our model should learn uncertainty on top of what is considered clean, if that makes sense. But we haven't really investigated that actually.
I guess this comes down to having a large enough training data set, which contains images. So maybe until there are more questions from the audience, I can add one on the scheme you used for this decoupled training. I guess your assumption of independence is quite a big assumption. And I wonder if there's empirical ways to test its validity. And secondly, whether the order of training the teacher networks, adding more eyes of augmentations in artifacts has an influence on the final student model.
What was the first bit? Sorry, again, could you remind me?
Firstly, is there a way to empirically test that your independence hold?
Right. Is there a way? So we tried to test this on just toy examples. So just taking images, adding noise to them, and adding noise to just part of the image. Yeah, I don't know exactly how we can investigate this.
I mean, did you try out combining two types of artifacts and see whether I think in your visual results there's always one type of artifact shown?
Yeah.
Did you try out multiple ones?
We did try. We did find that the more artifacts that you try to decouple, then the harder it is to learn.
Right.
And also certain artifacts can look very similar. For instance, like motion and blurriness can look very similar. So I'm not entirely sure what the model will do, where it will put the uncertainty into the motion or the blurriness output. That needs further investigation.
and the order of the adding of different artifacts to your training teacher training.
Yeah, the order of the artifacts. Yeah, we try to kind of emulate how the artifacts might occur in the real world imaging process. So so patient movement might be the first thing we add, and then we add noise due to, say, receiver coils, and then blurriness might be the last artifact due to image resampling. So we try to respect the imaging pipeline when we add artifacts, but
okay, that's reasonable.
But I think the way that it trains, because we freeze each network and train each augmentation individually, the actual order of training doesn't matter, because each network only sees one kind of artifact. It's only the final network that sees all the previous artifacts. Then the order in which they're applied to images probably does have some importance. But again, that's something we need to explore.
Okay. So just to wrap up, a quick final question from the chat. Whether you consider applying this architecture, or whether it's applicable to other modalities than MRI, could you consider this for CT artifacts, for example?
Yeah, I reckon it could definitely be applied to other modalities, but it's heavily dependent on the augmentation procedure. So you'd have to completely do a CT-specific augmentation pipeline, because the uncertainty is learned from the data in an unsupervised way. The augmentations are actually very important for the uncertainty to correctly work as a image quality indicator. So yeah, you'd have to change the augmentation pipeline, but yeah, I think it could work.
Great. Thank you a lot for your great talk and answers, and thank all the other presenters of this session, and Carol, my co-chair. With this, the oral session comes to an end, and we will run the teasers for the papers of the next session, and hope you enjoyed this one.
This is a teaser for our work on automatic PE diagnosis. PE is a pulmonary artery disease associated with high mortality, and the proper diagnosis and immediate treatment is important. The challenges of PE diagnosis include substantial false positive findings and being time-consuming. Therefore, we aim to develop a deep learning-based CAD framework to detect PE with high accuracy. We propose a hybrid training framework with two stages. In stage 1, we utilize pixel-level annotations to train the feature encoder network with attention-supervised training. Then, in stage 2, we utilize a large number of patient-level labels to train the PE prediction network. Compared with the previous state-of-the-art methods, we achieved better results on a much larger and more challenging dataset. The proposed framework is also able to provide localized attention maps that indicate possible PE lesions, which could potentially help accelerate the diagnosis process.
For more details, please refer to our presentation and paper.
Hello, my name is Darwin Yi, and here's a teaser for our work on training on annotations with multiple false negatives. Most datasets have pristine labels like what you're seeing here. But what would happen if we knocked out or censored half of our lesion annotations? Come to my poster and read our paper if you want to learn why this doesn't mean the death of a project. We got figures, we got histograms, we got mathy stuff. Come check out how to become robust to missing annotations and scale up your datasets.
Streamlining digital prognostic framework has many benefits and thus has been the object of much research attention. Our research proposes an assessment protocol for analyzing visual manifestation of 1920 cogain, which is a prognostic biomarker. We assess the presence, characterization, and reproducibility of the mutation biomarkers. To tackle such a limited, diverse, and unbalanced dataset, we propose a novel generative framework called FeedGAN, which is feature disentanglement GAN, to assess the reproducibility of the biomarkers. Such a framework also doubles as an effective data augmentation tool. We demonstrate that we can detect, reproduce the unapparent visual biomarkers. Our results, such as one on the screen, show that the feature disentanglement with selective training and semi-deterministic sampling is quite effective in tackling many problems associated with limited yet highly diverse datasets.
Hi everyone, my name is Ashraf Essunali. In our work understanding Alzheimer's disease structural connectivity through explainable AI, we used machine learning algorithms and machine learning interpretability and explainability in order to understand dementia. It's a new work perspective of using explainable AI instead of developing new complex algorithm. By training an adapted version of brain-net cell in overconstructed DY MRI tractography over MRI images from a dataset, we could achieve a very good performance of classification while fine-tuning the model's hyperparameters. Meanwhile, we use features visualization techniques and ablation analysis in order to interpret the model's prediction and classification for better understanding of responsible regions of dementia. Thank you.
Fast mitochondria detection for connectomics. In connectomics, we acquire high-res images of the brain. In these images, we are specifically interested in the dark circular structures that are mitochondria. Here highlighted in red, with a variety of different shapes. As part of this work, we released 2 new training and benchmark datasets annotated by experts in a consensus-driven process. Then, we train a UNet with reduced complexity. We're able to decrease the number of parameters compared to Ronneberger's original method by 93% without losing detection performance. Our method is fast and accurate. We detect mitochondria in real time with over 15 megapixels per second. Our method yields a competitive IOU of 0.942. Code and data are openly available. Thank you.
Hello everyone, I am Mohammad Minhajul Haq, a PhD student from the University of Texas at Arlington. This is the teaser video of my MIDL 2020 full paper, which is adversarial domain adaptation for cell segmentation. In this paper, we propose a cell segmentation network utilizing domain adaptation technique with the help of annotated dataset. At first, we propose unsupervised domain adaptation network, then we extend it to the semi-supervised domain adaptation. Here is the complete architecture in which there are 3 modules. In our experiment, we used 2 public datasets. And from this table, you can see that our method outperforms 2 baselines and it becomes very closer to the upper bound. Here is a visualization from our first experiment, and this is the conclusion. Thank you, and please have a look at our full presentation video.
In this work, we focus on cross-domain calcified plaque detection, given only have labeled lung contrast CT. The idea is to translate the image from contrast-enhanced CT to lung contrast CT and use the lung contrast CT plaque detector. We first train image translation model using current method. The calcified plaque is scrapped after image translation. To better preserve the plaque structure, we propose 2 solutions. First, extract small size image patch. Second, constrain the image patch in local clusters by using a subspace model. Show the translated long contrast images by our model. The small plaque structures are preserved much better. We also show the quantitative results on cross-domain plaque detection and segmentation using Mars-Car CNN. Our model shows consistent improvement compared to the baseline model. Thanks for everyone's time, and please come to our presentation.
Hello everybody, I am Xin Li. I'm excited to present our work, WISP, an automatic medical image interpretation system. Many existing methods use a coarse grid of image regions as the visual features to generate report directly, whereas our approach first predicts and localizes the disease as the semantic features, then followed by a report generation. To do this, our workflow first annotates an X-ray image by classifying and localizing the disease, and then generates the corresponding sentence to build up the entire report with an attentive LSTM. In this way, our system is capable of accurately annotating X-ray image and generating quality reports, which also provides visual support to help radiologists to make diagnoses. Thank you.
Hi all, I'm Raghav Mehta and I'm going to present our work on uncertainty evaluation metric for brain tumor segmentation in MIDL 2020. Automatic brain tumor segmentation is useful for a variety of clinical tasks, but usually these automatic methods make mistakes, which hinders their adaptation in a clinical setting. Uncertainty generation methods like Bayesian deep learning methods allow confidence in the model output to be conveyed. But how do we quantify this uncertainty such that it makes sense in a clinical setting? In this work, we try to answer this question by developing an uncertainty evaluation metric for brain tumor segmentation tasks. We use this metric for ranking methods in the last stage Pratt's quantification of uncertainty in brain tumor segmentation sub-challenge, and we are organizing the same this year. For more information about the evaluation metric, please come by our virtual poster session from 1:30 p.m. to 3 p.m. on Wednesday, 8th July.
This talk will explain the multi-organ segmentation method called multiple resolution residual network for the automatic segmentation of thoracic organs at risk from CT images. The MRN, which has been published previously by our group, has the capacity to simultaneously combine information from multiple feature streams computed at various image resolution levels through residual connections. We trained this approach on an internal data set of patients with lung cancer for the segmentation of the left and right lungs, heart, esophagus, and spinal cord. Our method was then tested using a public dataset provided by the 2017 APM Thoracic Auto Segmentation Challenge. And the results show that our network outperformed the best performing methods from the APM Grand Challenge for the esophagus, as well as achieved comparable results for all other structures.
Hi everyone. Here's a brief overview of our work on artificial intelligence-assisted MRI screening for pediatric cancers. When children are born with genetic conditions of cancer predisposition, they are encouraged to follow a well-established annual whole-body MRI screening protocol. Unfortunately, analyzing these images is very difficult for radiologists, and naive machine learning methods, which have shown promise in many imaging problems, are infeasible due to data scarcity and class imbalance. To overcome these issues, we augment a set of real whole-body MRI images using 4 GAN architectures and reformulate the problem as anomaly detection. We show that the StyleGAN2 architecture generates more realistic images, and in our extended abstract, we demonstrate that domain Fréchet distance is a more appropriate metric than Fréchet inception distance when comparing the quality of generated images. Finally, we demonstrate a proof of concept of GAN-based anomaly detection methods, including ANOGAN, and show that using the discriminator as an anomaly detector outperforms the classical watershed method.
We still see many participants entering the Zoom link, so we'll wait maybe 1 more minute. Hello, everybody. Welcome back to the MIDL 2020 plenary sessions. It is my great pleasure to introduce the last keynote speaker of this conference, Professor Elsa Angelini of Imperial College London. Elsa is well known for her work in probabilistic models for medical image analysis in a variety of clinical applications, including brain, heart, and lung imaging. She is a pioneer in using unsupervised machine learning to increase the understanding of lung disease, and that is also what her keynote talk of today is about. Elsa has worked in many different places, including Paris, France, Columbia University in New York, CSIRO in Brisbane, Australia, and she is now the co-director of both the Hefner Biomedical Imaging Lab at Columbia University and of the Data Science Group in the Institute of Translational Medicine and Therapeutics, which is part of the Imperial Biomedical Research Center. Elsa is a very prominent member of the medical imaging community. She was the chair of conferences such as SPI Medical Imaging and of ISBI, the chair of the steering committee of ISBI and of IEEE TMI, vice president for technical activities of IEEE Engineering in Medicine and Biology Society, and associate editor for several high-impact journals. And those are just some of the important roles that she has taken on in the past years. Elsa, I think you're not a regular MIDL participant yet, but we are hoping you might become one, and we are very much looking forward to your talk.
Thanks a lot, Marlene. It's really, thanks a lot for all the organizers for giving me this opportunity to give this keynote today. Of course, it would have been very nice to be all together today, but I'm also super happy that because of this online setup, maybe a broader audience will enjoy, hopefully, the keynote speech that I recorded. I have to say it was quite stressful, so maybe you'll feel that in my video. But what I try to do basically is to give, especially for the younger audience, testimony of a 7 years project that was done at Columbia, and that is still going on, and I'm still working on that now remotely from London. But basically, telling you a story about interacting with clinicians, believing in unsupervised learning while you don't really know where you're going, and how important iterating and validating again with clinicians is. And the last aspect is you'll see is the benefit, but also the challenges of working with very large cohorts of people. So I hope you will enjoy. Thank you.
Hello, my name is Elsa Angelini, and it's my great pleasure and honor to have been invited today to give a keynote presentation on a project that we've been working on for the past 10 years at Columbia University, looking at unsupervised learning and domain adaptation for subtyping of emphysema on very large cohorts of lung CT scans. So to start with some background information, we are looking at the respiratory system, and in particular emphysema and association with chronic obstructive pulmonary disease, or COPD. COPD is the 4th leading cause of death in the world. It affects 16 million of subjects in the US, and emphysema corresponds to destruction of the alveoli walls, those small units here in charge of gas exchange. Emphysema is smoking related, it's age related, but it's also genetic related. and the exact mechanisms for developing emphysema remains mostly unknown. So the baseline hypothesis for all this work was that lung texture learning for emphysema subtyping can advance COPD disease understanding. So we're using computed tomography, CT, scans to look at the lung structures. And those are acquired in the single breath hold, which is enabled by modern CT scanners. So those are very large image files with a sub-millimetric resolution, large matrix size, and intensity values which are calibrated in Hounsfield unit, but which are also in a very large range of values, from negative to positive. So if you talk to clinicians, they tell you that, well, you have 40 megavoxels of lung tissue to look at in a single scan, and that should enable in vivo study of lung structure and disease patterns. And in particular for emphysema, this is an illustration here of a subject where you can see those small pockets of air, which corresponds to regions of emphysema, and this can be small like this, or this can be much larger, as in this example here in the bottom. So quantification of emphysema has been done for years by clinicians, and using a very simple approach based on the histogram of the scans. And they typically would use thresholding at a fixed value, for example, minus 950 Hounsfield unit, to compute what we call percentage emphysema, which is the percentage of lung that is below this threshold value. Sometimes people also use things a little bit more sophisticated, like percentile density, to define the threshold based on the individual CT scan. In parallel, subtyping of emphysema is also an old idea and has been defined at autopsy, leading to three very standard, what we call standard emphysema subtypes that have been used a lot in the clinical world, and those are called the centrilobular emphysema, the panlobular emphysema, and the paraseptal emphysema. Unfortunately, when you ask a radiologist to score or to localize this type of emphysema on an individual CT scans, there's very limited inter-rater agreement. So this project all started with the data, and basically clinicians at Columbia University coming to us and seeing if we would be interested in collaborating and working on emphysema subtyping, given the very large cohort they had access to as being one of the screening center for the acquisition of those images. So those cohorts are called MESA, Spiromics, and MCAP. MESA stands for Multi-Ethnic Study of Atherosclerosis. Spiromics stands for Subpopulation and Intermediate Outcome Measures in COPD. And MCAP, which is a smaller, older cohort, stands for Emphysema of Cancer Action Program. So that's the initial table of data we were working with. And you can see the different studies here, the number of patients with CT scans, total number of CTs, etc. One thing to note is that MESA is what we call a non-disease cohort, as these didn't focus initially on lung disease, and there are a significant number of non-smokers recruited in this cohort, while Spiromics is a disease-specific cohort which enrolled people who smoked more than 20 pack years. The other thing to notice here is that both cohorts here have GWAS data enabling genotyping of any markers we would discover on those data. So as a start, when you balance the positive and the challenges aspect, on the positive aspect, those are massive prospective and longitudinal cohorts with a follow-up of up to 10 years in MESA, and here 3 years at that time in Spiromics. It's multicentric, which is really good for machine learning. Those are standardized CT protocols with quality control, which means basically this is the best you can hope for in terms of lung CT scanning. Data comes with state-of-the-art quantitative clinical measures of respiratory symptoms. And the lung and the airways were segmented by a single reading center, which is also good to have some systematic reading by a single center. On the challenging side, well, it represents 10 years of CT scanner generations, and this technology evolves quite a lot over the years. This means also that even for a single generation of CT scanner, you have multiple scanner types to deal with. And when you deal at this level of numbers of CT scans and participants, there's always a huge effort for database management. And finally, you get into MESA and Spiromics governance, and which I will talk about in the next slide. So overall, 11,000 full-lung CT scans, 35,000 cardiac scans for over 12,000 participants over up to 10 years of follow-up. So when you want to work with MESA and Spiromics data, you basically enter what I would call a multi-centric cohort ecosystem in the sense of a complex network or interconnected system. And you can, both cohorts have a public website with a lot of very interesting information. And as you can notice, they also have some tabs here, which are called publications and ancillary studies, and the same here for Spiromics. And those two tabs are basically governed by two different committees, the Publication and Presentation Committee and the Ancillary Studies Committee. So the first thing you need to do if you want to do any kind of analysis on those cohorts is to get some ancillary study approved, which means you need to write a mini grant, mini proposal with quite detailed strategies on terms of your hypothesis, what you want to look at, and how you want to look at it, and what type of outcome and advancement that would lead to. And if you want to submit that for funding, for a grant call, you need to be basically prepared 8 weeks before the deadline. So your whole calendar is completely shifted, and you live in a kind of a very different schedule as anyone else. And also, whenever you want to write a paper, you also need a paper approval. And if you want to submit a paper to a conference with a specific deadline, your calendar is also shifted by several weeks ahead of the deadline, so that you get your manuscript or even your abstract approved by the specific committees. The other thing which is a little bit of a constraint, is that it is your responsibility to avoid any overlap with manuscripts already in progress or published, which means if you want to replicate a study that has already been done, you need very good reasons for that. And you need to convince the committee that you have a good reason. And finally, you need to have all co-authors approving and having seen and approved any proposal you submit. So you cannot include any last-minute co-authors in this kind of ecosystem. So when we started about 10 years ago, the first thing we looked at is what's the current state of the art in terms of quantitative emphysema analysis on CT scans. And basically, there were no emphysema segmentation tool available. The machine learning was only done in a supervised fashion, mostly by a group in Netherlands. We had a feeling that spatial localization would matter, as we knew from even the standard radiologic emphysema subtypes that there were some different prevalence in different regions of the lung. And there were other cohorts also emerging in the field of lung CT scans, in particular around interstitial lung disease, and also the COPD gene, which is another massive cohort with lung CT scans. Right. On the other hand, we also had to think ahead about using cardiac CT scans to look at the lung, which might sound like a crazy idea, but not to the clinicians who already had a paper published in Academic Radiology showing that, or claiming that you could look at personal emphysema at population level with a very good accuracy on cardiac CT scans, even though you have degraded resolution and you could see only 2/3 of the lung region. And this was anyhow critical for us to aim for the same type of analysis on cardiac CT scans, because most of the scans we were given were actually cardiac scans. And that was also the only option for us to perform longitudinal studies over 10 years, which was really the goal of the collaboration. There are some extra data that come, again, with those CT scans. Lung masks were provided by VIDA. Emphysema, of course, masks were available by just using simple thresholding. We also had some visual annotation of standard emphysema subtypes on a subset of scans, which was done by one of our clinical collaborators. And also, at some point, we were given upper limits of normal in person emphysema values, which were basically adjusted individual reference value of the expected or the normal percent of emphysema for a given person, taking into account covariates such as sex, height, race, ethnicity, BMI, and age. So based on all that, the second hypothesis here is that emphysema is common in the general population in the absence of COPD, which was a really good news for us because we had to start working with the MESA cohort, which is again the non-disease cohort in terms of emphysema. And as shown here, if you look at baseline scans, the person emphysema in those scans has a median value of only 18%, which reduces quite a lot the number of voxels of interest in the CT scan, but which is still quite reasonable. So having all that and discuss with the clinicians, the mission that we were given is to study and seek purely radiological emphysema subtyping, which means we had no access and no use of any demographic or clinical measures. But of course, we had information on scanner type and or reconstruction filter type that were used per scan. So to conclude on this background information, the first thing we had to do is to develop our own emphysema segmentation tool, which would be really reliable at the individual level. We did that using a hidden Markov mesh field, and we called the associated person emphysema the HMMF person emphysema. And so it's a statistical method leading to pixel-wise labeling of emphysema, and which was published here. And one of the things that took us a lot of time is actually the parameter tuning, especially for the spatial regularization, which is illustrated here, as image quality, again, can vary a lot, even for the same subject scan with two CT acquisition using different reconstruction filters. So without any ground truth, the thing we looked at is the evolution in time of the person emphysema at the individual level to see if our approach would seem to be provide robust measures and plausible measures of progression of emphysema in time. And as you can see here, our measure grows steadily over years between 2004 and 10, while thresholding can show a lot of variation and especially decrease in emphysema measurement if you change scanner type. And the one interesting thing that we saw here is that if you do a little bit of Gaussian smoothing prior to thresholding, that stabilizes a lot your measure, even though it's still not really completely reliable. And so again, as a proxy of validation of our approach, we use normal subject here from MESA. And we showed that on the population level also, we had a very steady increase of emphysema over years using our segmentation method, and that the rate of increase corresponded to the clinical rate that is used as the reference by clinicians. So what we learned in this first phase is that CT scans vary greatly, despite what you can read in a textbook. That parameter tuning is key and can take a lot of time. Gaussian filtering can help in this type of data where you have lots of texture, but also quite some noise sometimes. And using normal cases was really key for us in this initial phase of development. Now moving on to the method section, I'll go over our strategy for spatial mapping, unsupervised learning, and domain transfer. So the development for unsupervised learning took about 4 years, spending the first year on, again, gathering, preparing, and learning the data, knowing that we only had images in our hand and that deep learning was not yet an option at that time. And we actually spent quite some time on agreeing on the best way to sample region of interest, RI, in the individual scans, knowing that it was not possible to use all emphysema RIs from all individual scans. Then we spent basically 3 years doing unsupervised learning and iterating very regularly with our clinical collaborators to discuss those subtypes and inspect them via, for example, looking at their appearance, their spatial prevalence, as illustrated here, and iterating with them so that everybody was convinced that the subtypes are plausible, are reproducible, and are meaningful. And that goes through, again, a lot of evaluation metrics such as measures of reproducibility, measures of association with clinical symptoms done by the collaborators, and also measures of association with the standard emphysema subtypes. Once we were all happy with our subtypes, we then moved on to handle the cardiac CT scans and being able to label emphysema subtypes on those scans, and this is where we use deep learning. And basically after 4 years, we were ready for the final end goal of the project, which is genetic association between emphysema subtypes and genes. And this is done via GWAS analysis. This is performed by an external collaborator. And so that, those analyses are really massive efforts. They need as many samples as you can, but in the thousands. And they are very costly to run. So basically, you only reach that stage once the clinicians are completely persuaded that what you have in hands and what you're proposing is really solid biomarkers. So our approach, we started with standardized lung shape spatial mapping because we wanted to have access to spatial localization. And then we developed a 2-stage unsupervised framework combining spatial and texture information. And finally, again, domain adaptation was used via adversarial deep learning to handle the cardiac scans. So regarding the lung shape spatial mapping, we used a very old idea of encoding shapes using Poisson equation. So having a lung shape here, we're segmented with a lung mask. We first define a patient-specific core position inside the lung, and then we use Poisson diffusion to encode every voxels in the lung with a radial coordinate that defines the distance from the core to the pil being the outside surface of the lung. And we also augmented that with 2 radial coordinates, theta and phi here, so that we also could encode the position in the anterior, medial, posterior, lateral plane, and also the inferior to superior plane. So this is what we call now Poisson distance conformal mapping. And this is actually really nice to have such tool to spatially align lungs without requiring any registration. And this is very analogous to what is done in neuroimaging to map brains on spheres. And just with this simple tool, we were able, for example, to generate first-time atlases of the lung. For example, here, just looking at the Hounsfield units of within scans. And on this small cohort of non-emphysema subjects, if you project the average intensity values in a normal population, you end up by visualizing very clearly what is known as the gravity effect, and which leads to having attenuation values in the anterior part of the lung with darkest attenuation values than in the posterior part of the lung. And from this normal population mapping, then we can also, for example, generate relative intensity projections in emphysema population. And this is using the subcohort that was visually annotated by experts as being dominated by centrilobular, panlobular, or paraseptal emphysema. And again, there's lots of information here that you can evaluate. And for example, confirmation that the paraseptal emphysema has a preferred or darkest here with the darkest density preferred localization toward the pil rather than the core of the lung. All right, then the first step for the really, in this sense, the unsupervised learning was to encode regions of interest, ROI. So we used a cubic ROI of this size, and we equip each individual ROI with a particular sampling strategy inside the lung. in terms of texture features and spatial features. The texture features were based on text, while the spatial features, again, use the location encoding that I just presented in the slide before. And then we used a very classic, as a first step, a very classic clustering approach, where we iteratively update a write assignment in an individual long texture pattern, LTPs. So by minimizing a dedicated cost function, which is composed of 3 terms to constrain texture distance, to enforce spatial regularization, and to also enforce some texture penalty differences. We worked with an arbitrarily large number of LTPs in this first step, and here we chose just to work with 100 LTPs. Once we have those the centroids for those 100 LTPs, we move to step 2, where we define what we call spatially informed long texture patterns, SLTPs. And for that step, we chose to use the InfoMap graph partitioning algorithm, which is fully unsupervised in the sense that it also decides itself on the final number of clusters. To encode the similarity between the nodes in the graph to be partitioned, we relied on a notion of replacements and saying that 2 LTPs are similar if they replace each other when one is removed out of the pool. Doing that, we moved from 100 LTPs to 10 SLTPs. All right, in terms of evaluation, once everybody was happy with this type of pipeline, what we did is use the spiromics, so the disease cohort that we first split into 2 subsets, which we call training set 1 and 2 here. And we learned SLTPs using those 2 subsets independently. So we end up again with a series of 10 SLTPs, which have some similarity, visual similarity, and also some similarity in terms of spatial prevalence, which is encoded here. And what we did for as a validation is to measure 2 things. One is the reproducibility of SLTPs across those 2 learning experiments, and we measured reproducibility at the regional level as a percentage of labeling overlap of test ROIs, and also at the individual level, measuring the correlation of SLTP histograms within individual subjects, and both reproducibility were super high. And finally, we also tested the ability to encode, for those subtypes, to encode the standard emphysema subtypes, which is very important in terms of clinical relevance, and intra-class correlation were very high for the 3 subtypes. Moving on, then we retrained again using the whole spiromics cohort now, and we decided that that would be our final SLTPs. So with those, which ended up again to be 10, we moved on and labeled all these individual scans in spiromics and in MESA, leading to those very nice maps, but also to histograms, which are a kind of signature of emphysema in individual subjects. And using those histograms, we performed some population clustering to see if we could maybe further reduce the number of SLTPs. And we actually did, and we moved on from 10 SLTPs to 6 quantitative emphysema subtypes, or QES. And those subtypes were reviewed also by collaborating radiologists who agreed with the aggregation of SLTPs and who also came up with nice names for those QES. So currently we have 6 QES, which are called apical, diffuse, vanishing lung, senile, and 2 CPFE type. CPFE stands for combined pulmonary fibrosis and emphysema, and those 2 types are either restrictive or obstructive. Having those QES, if you look at their distribution in the whole population, you can see that, you can see several things, and comparing MESA and spiromics. First, you can see that some QES are rare, and especially the vanishing lung is only observed in the disease cohort. The apical is also very prevalent in the spiromics, the disease cohort, while it's quite rare in the normal cohort. On the other hand, for example, the senile QES is equivalently prevalent in the 2 cohorts, which tend to make sense. The second thing we looked at is the clinical significance of those QES in spiromics and MESA, and that means measuring association of QES with respiratory symptoms, physiology, and prognosis. So there's a lot of information here. This is for individual QES here per columns. And the red shading basically indicates statistically significant association in the sense of worsening symptoms, while the blue and green shading indicates statistically significant improvement. And we also evaluated here association with outcomes such as hospitalization and mortality. So being done with the discovery of emphysema subtypes on full lung CT scan, we moved on to labeling those same subtypes on cardiac CT scans. And while everything looks good when you look at an axial slice of such cardiac CT scan, you immediately realize that when you look in the longitudinal direction that you've lost a lot in terms of texture resolution. And this is because of a factor of 5 in slice thickness between full lung and cardiac CT scans. So basically, we are facing 3 challenges. First, we are missing the apical region of the lung. Second, we work with degraded texture. And third, we have to handle a very large set of scanner types, which varied a lot across several years. So how do we do the emphysema subtype labeling? Obviously, we can't work directly as before, and we need to be quite innovative here. So the first thing we needed is actually to detect where emphysema was present in those cardiac scans. And so we had to figure out a way to perform emphysema segmentation. And then once we have the emphysema voxels in those scans, to perform the labeling, we exploited deep learning and for domain adaptation. And this deep learning, basically, the key idea for this deep learning was that we have full-lung CT scans with ground truth labeling of emphysema subtypes, and we generated synthetic cardiac scans to be able to have a supervised learning of the labeling and added to a domain adaptation so that what we were doing on those synthetic scans could be applied to the real cardiac CT scans. And at the end, we ended up with over 17,000 longitudinal cardiac and full-lung CT scans being labeled with emphysema subtypes. So scaling up a lot what we were able to provide for the final GWAS analysis. So first, regarding the segmentation, where we revisited the HMMF segmentation method, and we spent quite some time in doing parameter tuning for all the hyperparameters of the method. So for the full lung CT scan, as I mentioned, we ended up having scanner-specific parameters, especially to parameterize the statistical distributions used to model the emphysema and the normal lung tissue. And here for the cardiac scan, we came up very quickly to realize that we needed also to use some subject-specific parameters, especially for the normal lung tissue mean values, as it varies a lot between scanner types, and this is easily inferred by the outside air value in individual scans. So in terms of validation of this segmentation, again, we don't have any ground truth, so we exploited 2 things that was available in our data. First, for some subjects, we had 2 repeated cardiac scans acquired at the same visit. And that's really gold because you know here that whatever you're segmenting should be highly reproducible. So we first looked at the population level reproducibility of percentage of emphysema measures. And here, this is again a nice confirmation that actually at the population level, if you compare personal emphysema in the first scan and the repeated one, any method being thresholding with filtering or HMMF, you get a pretty high reproducibility. But now if you look at the individual level, looking at the dice overlap, so really pixel-wise overlap of what you have segmented in the repeated scans, then HMMF made a big difference and led to a very significant improvement of the dice value compared to thresholding. And this is illustrated here on the overlapping maps of emphysema voxels segmented using thresholding with Gaussian filtering, and again here the HMMF where you almost see green true overlap pixels basically. and very little disagreement. The second thing we did as an evaluation is to exploit the fact that we had longitudinal cardiac scans in exam 1 to 4, and versus and then a full lung scan in exam 5. And so we looked at the pairwise correlation value on those longitudinal scans within a very short time period of 18 months, and among normal subjects where you expect a very small increase in personal emphysema. And this is what you can see here is that the baseline cardiac exam and the follow-up exam, cardiac exam. You see, well, on population level, again, thresholding is not so bad, and but emphysema seems to be slightly more correlated, and that's confirmed by the numbers here. But at going to, again, the individual level, if you want to really follow the individual base increase in or progression in emphysema over time, and here this is comparing also for doing this evaluation for normal subject and for disease subject. Well, you clearly see on the blue lines here that you get a steady increase and, as expected, increase of emphysema over time using the HMMF segmentation, and also that disease progress more than normals. While for the thresholding, well, it's not too bad if you remain in the cardiac scans. When you switch to the full lung scan and you compare personal emphysema, you see a major problem here, and realistic decrease in personal emphysema. All right, so once we had this segmentation tool, then we were ready to do domain adaptation and what we call unsupervised domain adaptation with adversarial learning, UDA. So the idea here is that we work with two domains, a source domain and a target domain. So the source domain are those synthetic cardiac scans that we generated by just downsampling the full lung CT scan. And the target domain are all the real cardiac CT scans that we had. And equipped with that, you can feed those RRIs to three neural networks. The first one, which is the feature extractor, which works on both source and target domain. Then we have a second network for the image classifier, which works on the ground truth labeling that we have for this source domain, and a third neural network, which is the domain discriminator, and which evaluates, which tries to discriminate between the two domains here, the synthetic scans and the real cardiac scans. And the loss functions then is a balance between the classification loss and the domain discrimination loss with this parameter alpha. So, oh yeah, and I forgot to mention that it didn't work immediately, and we were at some point a little bit desperate on why it was not working. And actually, one of the key things we have really to pay more care than we thought was on the sampling of the ROI. So, and this is all explained in the paper, but basically we ended up with really paying great attention to where we were sampling for the same subject on synthetic and real cardiac scans, so that they would be in good correspondence. All right, so the data we worked with is detailed here. So the split for the training, validation, and test set was based on the full lung CT scans available in the MESA exam 5. And once we had split our subjects into training, validation, and test set, we applied, we selected the same subjects and their cardiac scans available across the different generations of exam from 1 to 4. And the good thing is that we're lucky enough to have enough samples that we were able to distinguish training for actually 3 target domains, which are helical scans, MDCT scanners, and EBT scanners. And you have the numbers here. And as you will see in the results, that was really key, because actually those target domains are really different and really benefit from having a UDA trained specifically for them. So how did we evaluate the UDA framework and the quality of the labeling of emphysema subtypes on cardiac scans? the first thing here is that we looked at, so just focusing on the synthetic cardiac RI in exam 5, compared to the real cardiac RI in exam 1 to 5, what we looked at, so this is really at the RI level, what we looked at are two things, the what we call the accuracy in classification. So that's the SLTP classification accuracy on synthetic RI. And then the domain accuracy, which is the domain classification accuracy on real versus synthetic RI. And here we compared UDA to the alternative approach to see the effect of this domain adaptation. So, and what we call CNN here is just using the first two networks without any domain discriminator encoded in NN3. And the last thing I'll mention here is this alpha max was optimized and determined by maximizing this accuracy, total accuracy, which is the accuracy of the classification minus the accuracy of the domain discrimination. And this minus here, I didn't mention that, but this minus here is important because the whole goal and the whole concept here is that you want to work with features that are invariant in domains, so that are not capable of being a good, training a good discriminator between domains. So at the RI level, validation accuracy for SLTP labeling and domain classification in MESA exam 5 led to the following. And two things that we learn here. So if you look at the classification accuracy, what we can see is that we get adding a domain adaptation to the labeler, pipeline, leads to a slight decrease in SLTP classification accuracy, using again our supervised ground truth cohort. On the other hand, regarding the domain adaptation, we can see here that the UDA, so again, the lower the better, has a much lower and so much better domain discrimination accuracy for what we want to do. That alpha max varies a lot across target domains, and that if you were just using the classifier features to do domain discrimination, then it does a much better job. So, which is against what we wanted to do and use, again, the domain invariant features. All right, so moving on, we then evaluated the SLTP labeling in MESA exam 1 to 5 at the individual level. So to do that, we did two things here that are summarized in this table. First, we compared the labeling using the synthetic data versus real cardiac scans that were available for the same subjects. And this is again distinguishing the three target domains. And then we moved to the just comparison of two real longitudinal cardiac scans, where we identify the target domains as for baseline and follow-up. And here you see there are pairs of cardiac scans where there's no domain change. And here, finally, the pairs of follow-up baseline and follow-up where there was a change in the scanner type between the two. So this gives you an idea of the number of subjects available, the number of SLTPs detected in those scans. So not always the 10 SLTPs are being labeled. And finally, some two metrics, so the chi-square distance between the SLTP histograms and the correlation value between the person SLTP in the pairs of scan. What is in bold corresponds to significantly better performance, and basically UDA wins. So domain adaptation, confirming that domain adaptation really is beneficial in what we're trying to do, and leads to higher correlation here. And also here, especially, so one of the great gain was when there is a scanner type changes, as seen here, where we both improve the correlation between SLTP, percentage of SLTP, and the distance between the SLTP histograms. And this was done, on pairs of MESA acquired within a limited amount of time, so that there shouldn't be too much progression and too much changes in the SLTP labels. All right, and the last thing I wanted to mention, this is a short study we did last summer, where we actually went back to thinking about, could we try to do other things with those cardiac scans, like, for example, super resolution, or really some mapping between full long CT scans and cardiac scans. And for that, again, what we are really missing is the apical part, because without this, we can't equip the lung with any spatial coordinate, and then mapping becomes very difficult. And so we did this small experiment that I wanted to mention to you today, which is using GAN to infer from a cropped view like this of the lung mask to infer the full mask. And those are illustrations, of typical results we were to obtain comparing to the ground truth, which is here. And that was actually pretty easy to train, and this led very quickly to good visual results. So one of the tricky part was actually to figure out a good thresholding as we were generating non-binary maps. And this is where it took a little bit of time on the validation set to come up with the best thresholding strategy. But overall, the DICE score are very high, either for training, validation, and test set. And so that's the strategy we might pursue in the future. And I have to say, even if it looks like a simple basic study, the clinicians would find also a lot of interesting options by having such tool. So now I will conclude in two parts. First, what's next? Well, basically with the renewal of our NIH grant, we are now looking at what we call deep and molecular QES. We're working with the latest generation of MESA exam called MESA exam 6. And with that, we are first now looking at adding some temporal regularization in the labeling of our QES. Then we will move toward deep QES by adding information from expiratory and angiography CT scans now available in the MESA cohort. And then moving on from deep QES to molecular QES by adding genetic information. And this is all, again, still evaluated via association with clinical symptoms. The second nice things that we are moving toward is to use now a new cohort called CanCode, coming from Canada, as a replication cohort for all our learning process. In the second part of the grant, we looked at explanted lungs with micro-CT, which is the GRAL, basically, as you can then confirm what label QES has seen on CT scans really look like when you look at the tissues. And finally, the third goal is to go into the clinical world and translate our quantitative emphysema subtype on low-dose clinical scans. In parallel, we are working now still in the concept of unsupervised learning into quantitative airway tree subtyping. And the goal here is to understand the role of variants as seen in the general population in COPD. The second thing, part of my conclusion, is on lessons learned that I wanted to share with you, and in particular with the young audience today. And as a first message, I would really encourage you to discuss your method with clinicians as often as you can and learn to speak their language. This is an invaluable resource. Clinicians are usually very happy to discuss methods, results, and strategy to evaluate your results. And also, this is absolutely mandatory to really work very closely with clinicians if you want to write any grants, such as for the NIH. Know your data, so in particular, know the physics of imaging when you work with medical imaging. And on the other hand, don't assume too much regarding consistency in imaging, in particular when you're working with very large cohorts and with CT scans that evolve a lot in time. Ancillary studies and proposals can be an asset rather than a nuisance. I actually find it now very interesting and useful to agree very much ahead of time and on paper on what we want to do, using what data, what kind of method, and what kind of evaluation to use. And the other nice thing is that when you work with MESA and Spiromics, you're really part of, again, a big community of investigators that work on the same data. So, and when you get feedback from the committees reviewing your proposals, you usually get very interesting feedback, and also you know that everybody is aware of what you are trying to do, and that you're doing something that is different from other people. Finally, small tasks such as measuring percent of emphysema or registering cardiac scans, which I didn't detail today, but we had to do at some point, are not always easy, even though they sound, simple and basic, and they can take you a very long way. And this is what happened to us last summer, where we were included in a big JAMA paper studying the influence of air pollution on emphysema and lung function, and where basically our measure of percentage emphysema with HMMF was used as a replication measurement compared to thresholding confirming findings in this paper. Finally, dive into unsupervised learning. I hope I've convinced some of the people in the audience that this is an interesting adventure, even though it's very risky and it can sound frightening, because again, you have no idea of what you're looking for and what you're going to discover. But clinicians do, I think, rely on us to make really great progress and impact in subphenotyping disease. And that's basically the only way we can do that. Deep learning requires human intelligence, and especially when feeding the data. And that was really one big lesson to us when we worked with the UDA framework, that we had to pay more care than we were doing when sampling errors from the target and the source domains. A 10-year research cohort is heterogeneous, definitely, but that's nothing compared to clinical heterogeneity. So keep always that in mind when you're trying to be, too specific to a specific research cohort. And finally, I'll take this opportunity to ask reviewers in the audience that when you review unsupervised learning, be open-minded, because again, this is really challenging and this is really difficult. We were lucky to have a fantastic cohort of data to do this kind of work, but not everybody has access to such data, and they are still, I think, very valuable unsupervised learning strategy to investigate. And finally, acknowledgements. All this work was done in the Hefner Biomedical Imaging Lab at Columbia University, directed by Andrew Lane, and most of the work was performed by two PhD students, Ji Young, who is now at Google, and Iro Hammer, who worked initially on the HMMF segmentation framework. Thanks also to all the other students here who did some portion of the work. This was done jointly with Columbia University Medical Center and Graham Barr, who's the PI for the MESA and Spiromics acquisition at Columbia University, and some people of his team and collaborators who provided especially all the association with clinical symptoms. And external collaborators involving University of Iowa, in particular Eric Hoffman, and University of Virginia for the GWAS analysis. Again, thanks to NIH for funding this work, and thanks to the MESA and Spiromics committees for supporting our work, being positive on all proposals we've submitted so far, and having always very valuable feedbacks for us. Thanks for listening.
Thank you very much, Elsa, for this great talk and this very insightful record of a fruitful collaboration between clinicians and data scientists. To the audience, please ask your questions via the Q&A box that is in the bottom of the screen. We already have a few questions coming in. To start with, I was wondering, you have put a lot of emphasis on unsupervised learning for disease subtyping. And I was wondering, what role do you see for supervised learning in disease subtyping? For instance, directly learning to predict disease outcome in terms of lung function or decline?
Oh, I think there's a lot you can do in supervised learning if you want to bridge what you observe on images and the symptoms or the outcome, whatever outcome being. It's just here that was really again purely radiological investigation. So that was really the challenge. And I think if you want to do purely, this is disputable, right? Some people might think that this is the right way to do this kind of investigation should be always equipping the learning combining in the learning the imaging and the clinical data, for example. But in the mission we had, we only had the images, and I think in that case there was only, except relearning the standard emphysema subtypes, but the clinicians, thought from the beginning that they are not reliable enough because they are such this large inter-rater, disagreement whenever you ask radiologists to characterize that the only option we had was to go into unsupervised and let the computer, discover those textural patterns basically and integrate spatial location, in its own way to find those clusters. But I think, there's a lot to do with supervised learning as well, absolutely. And I'm doing a lot of those in other projects. But here that was really not an option.
Thank you. And so connected to that, we have a question that has come in from Kayhan Batmanjelic, who first of all wants to thank you for your nice note to the reviewers of unsupervised learning papers and grants. Given that there is a substantial difference in some emphysema subtypes, between subtypes, what is your opinion about defining subtypes in a fully data-driven way, unsupervised, and then map them approximately to the clinically defined subtypes?
Well, so of course, again, you can do that. You can do that, but I'm not sure I totally understand the question. So one thing, for example, we did in terms of being sure that those subtypes that we had were clinically relevant were to show that they were predictive of the standard emphysema subtype, but using only 3 subtypes where we had 6. And one of the things we think is that there are more one of the baseline assumptions is that there are more subtypes than those 3. And especially localization again. So maybe there could even be similar appearance of a subtype, but with different spatial prevalence. And this would be learned in the way, with our approach, why it wouldn't be done just by looking to purely radiological images. I don't know if that answered the question because I'm not sure I completely understood the question, but yeah, this is again, from the start, we knew we were not going to try to replicate any of the existing subtypes, which also were defined really at autopsy and not really on CT scans. So there was also this issue here, maybe between of a gap between the real appearance and what you can see on lung CT scans, and really can label reproducibly and accurately on CT scans. And that's part of the challenge right now that we, hopefully when we get those micro CT scans is to go back to the lung tissue now with our subtypes to see actually what they look like on the tissue.
Yeah, we can maybe go with a few more questions from the audience. Again, don't hesitate to ask a question on the Q&A as well. It's easy, just click and then ask your question. There's one from Anirban Mukhopadhyay. Probably I'm mispronouncing it. He says, great presentations. I guess an obvious question is, what's your plan on using these techniques for COVID-19? Chest CT data sets, basically.
Yeah, I saw the question. Of course, it's an obvious, transfer of because of the same scanning modality. I guess, okay. One thing definitely could be, just directly to look at the influence of effect of even the presence of emphysema and different subtypes on, an association with COVID symptoms or outcome. So that could be one. In terms of the sign of infections of the COVID specifically, like the ground glass opacification, etc., I think here, I don't know. At least from what I've seen, there's no really at least challenges in terms of segmentation and supervised segmentation, and it's working definitely fine. Those signs are clear enough and large enough so that usually they are detected accurately. So there's no immediate plan, at least in our project and in our group, to really extend any of this work, for example, or replicate that. Well, one of the things would be more interesting is to go into interstitial lung disease, and for example, on the high, high intensity value range rather than the lowest one, and do similar learning to do some subtyping of those different subtypes of ILD types of manifestation. So that's one thing we're considering, but COVID not really. No,
Yeah.
not for the lung infection side.
That's probably the
People
question.
have solved that already.
Yeah. Marlene, maybe?
Yes, so I'd like to ask another question from the audience, asked by Nicolas Trich. How did you choose the core point for the lungs in the Poisson mapping step?
Yeah, so it's a good question because it's actually not the same thing. It sounds simple, and it's not that simple because of the shape of the lung, the diaphragm can be really very variable, and if you just take the center of mass, you get high variability in the longitudinal axis. So we actually ended up with a small algorithm kind of constraining and kind of ignoring the top and the base part and just centering them relative to the outer surface of the lung, what we could call a good center of gravity. But we basically ignored the extreme values in some way so that it's not too much influenced by that. It's going to be out soon, hopefully, so you'll have all the details, but it's not super sophisticated, but it does matter indeed because for the good then radial values and mapping.
While we wait for maybe a few more questions, I have one from myself. You said that basically it's a super long project. What you're doing is extremely cool. Almost 10 years ago, no, you said it's. I remember back 10 years ago, in fact, the culture of sharing data was, I would say personally, I feel the culture of sharing data was very different from maybe today. I feel today, on a personal note, I feel today there's more open data sets, there's more data sets from challenges and so on. How would you see would you see a similar impression that I have, like a major change in, not necessarily major, but a change in culture in sharing data, moving from private maybe to public data sets, or is there drawbacks or any, what do you think basically of the change of culture, or do you see a change of culture?
A change of, I'm not sure I understood a change in for the sharing of data, right?
Yeah, particularly.
Like the spirit. No, I think it's fantastic. I think, well, obviously those challenges organized at MICI, ISB, and other conferences are really fantastic, and especially great resource for especially students starting in the field so that they can practice and experiment. Okay, in our case, definitely one of the, I think, luck we had again is that we had this very high quality control cohort. So we knew we were working with state of the art. So we knew that, and we had the confidence of the clinicians that we should be able to to reach this goal that they had for us in mind from the beginning. One of the risks, obviously, when you work with a public cohort is that data can be of more lower quality because it's just standard clinical scanning, and again, the drop in quality can be massive here, or the data has been processed, right? For example, brain MRI aligned together, and then therefore smoothed and really transformed from what came really out of the scanner. And this, I see this as a risk. So at least I would, my recommendation would be to always make sure you go into the details of check the headers, check all the information, and try to get as much information as you can on, for example, in CT, the CT scanners, the year, the KVP, all the parameters that, so that the dose, many, and it's basically in what range also of variability you're working with, because that matters a lot.
Yeah, public data sets, maybe it's better if they're closer to reality, as you said. No, they have to be a bit dirty, or somehow as well. On the other hand, it could be more cleaner.
No, yes and no, because again, I don't think if we had used clinical scans, we would have maybe, I think, learned such robust subtypes. We really worked. I think at least some standardization in the acquisition, I think is really key, because you're eliminating many sources of variability, right? Even though you're observing the same. and even with that, we had to solve many challenges over there. But so I think actually in our case, that was a very good idea to start with a high quality cohort before moving to the clinical work. And I don't expect the clinical work to be very easy once we move there to do a labeling on those scans, actually.
I'd like to ask a question that has just come in from the audience by Michael Tardy. You spoke a lot about how small tasks may take a lot of time, and how do you decide if a given small task is worth working on it? Do you have some general advice on that?
Well, at least me, I'm always very enthusiastic. Whenever a clinician comes to me with data and you know, a clear idea of what would be useful, I'm always usually happy to work on that, at least, you know, for a few weeks. Let's see where it goes. So in general, I would suggest never say, you know, no to small tasks. And there's also a lot to learn, and that maybe makes you, when you figure out it's more difficult than what you would have thought in Temple, and maybe also go back then more closely to the data. What's the problem? If it's not working or if it's not that easy, what's the problem? What did I miss in the property of the data that I assume, you know, would make this problem easy? And actually it's not. And also I think, at least I see, you know, us as a kind of a, you know, serving the clinical world and medicine. So, for example, this registration of cardiac scans, it was not fun. It was not, you know, super fancy, the method we developed. But again, we knew, the clinicians, you know, were telling us, you know, it's essential for us if we want to make these biomarkers, these measures across cardiac scans, which are, you know, not cropped at the same level, because you know, there are some random across scans, and also the inflation level. They need to know, kind of, they have an idea of the difference in inflation level, etc. You know, for them it's essential. So as long as you know that, I would say, you know, go for it. Really, I would. At least I would always encourage my students to go for it.
I think that's very good advice in general. I'd like to ask one question of myself as well. So, and now I forgot about it.
That's okay.
In your collaboration with clinicians, so you've showed that your unsupervised, with your unsupervised learning, you can actually uncover the patterns that clinicians already know are important, which is quite impressive, I think, that you can find similar emphysema patterns. I wondered if your research has also led them to a different kind of understanding of lung disease. Have your results changed their view on COPD?
Yeah, on COPD not yet, I guess, but on emphysema, so which is one of, you know, big part of COPD symptoms and origin. Yes, I really think so. That was really actually super nice when you know, one day you know, the clinicians, especially knowing that the radiologists spend a lot of time looking at our quantitative emphysema subtypes, and came up again with those names by looking at the appearance, looking at the prevalence, spatial prevalence, and looking also eventually, I think, at, I don't know exactly how they worked on that actually, because I was not part of the study, but they had all our label map and the scan next to each other, and they were looking at hundreds of scans, and they came up with this, with this approval and those naming, which I think make a lot of sense. And as you can see, some may be age related, some are more location related, some are more appearance related. And yeah, I think this was revealing for them, definitely. I think they were discovering a lot in terms of a new way to look at emphysema. It did confirm really their intuition that there were several subtypes, and that those three subtypes that everybody uses is really not fine-grained enough to categorize the population of emphysema and then of COPD for the disease cohort. So yeah, I think but again, it took really many iterations. The first subtypes we came up with were not necessarily convincing or too much variable, etc. So there was a lot of also trust, to gain from them as we were moving in the right direction, and at the end, this was solid, basically. But yeah, I think it will. I think it will definitely change the way they look at, or hopefully it will change the way they look at scans, to look at autism.
Yeah, maybe I have a question of myself as well. I see it's maybe related to a few that we see on the Q&A. And again, on our audience, don't hesitate to ask more Q&As as well. I see more and more trend as well in the machine learning community, computer vision community, a few at MICAI as well on new methods, exploring more and more the attention maps, for example, that could light up or learn different. Would you see? I'm not sure what my question is. Would you see something interesting there, or would you see it's more like a, yeah?
Yeah, no, we could certainly, I mean, at least for the activation maps, maybe also.
Yeah, activation maps, sorry.
Yeah, no, I think they are a fantastic tool. They work super well, in particular on lung CT scans. We've used some for lung nodules, and they were really very specific on the regions where even though we were doing global labeling as a cancer or not cancer, then you could see that the activation was really at the exact place, and same for COVID, what people have done. So no, I think there's a huge value there, and we are actually really now going to, that's one direction there definitely we want to take, and taking all this, also ideally all this labeling now into just deep learning labeling, and forget about the old standard vision text and approach. So no, I would say go for that direction, and maybe for example we could use those activation maps to do some further unsupervised learning and clustering to see if there's also some new insights on, or even subtypes that could emerge out of those activation maps that we would not necessarily learn by using those texture features specifically built for.
Cool. Yeah, thanks a lot. That's
no, thank you. That was really a great honor.
And I'm seeing as well the time is advancing, so I think we should maybe close the keynote, and not sure how to clap everyone.
Thank you.
And
thanks a lot.
Thanks a lot. Yeah.
Thank you.
Thank you, and we'll see everyone back in 15 minutes for the next oral session.
Making a difference to billions of lives is the aspiration of the healthcare intelligence team. I love doing research with a view towards having both technical as well as societal impact, especially in healthcare, where the potential for impact is very exciting. At Microsoft Research, I get to spend 100% of my time doing exactly that. Thanks to big healthcare data, there's a huge opportunity for AI to revolutionize healthcare.
At Imagia, we gather creative minds to reimagine healthcare and reveal the full picture of personalized health. By creating a collaborative ecosystem of the best clinicians and AI scientists, we are able to tackle some of the biggest challenges in healthcare today.
At CFAR, we see research differently. It's about more than proximity and disciplines. It's about asking the big questions and assembling the right teams to find answers, being bold and taking risks, supporting diverse researchers who achieve unprecedented advances in life and health, for individuals and society, for Earth and space, for information and matter, for the world. We support the risk takers. We enable big thinking. We bring together the brightest and boldest minds across academic disciplines and across borders to address science and humanity's most important questions. Together, we stay curious, and we will continue to provide researchers with the time and freedom to explore new ideas. As we look to the future, we will work from this premise. Fundamental research matters. Some of it changes what we know about the world today, and some of it will change what we know centuries from now. All of it fuels innovation and advances humankind. Join us.
Hello, everyone. OL is there.
In stage 1, we use image slabs and the corresponding pixel level annotations to train the network A. Then later in stage 2, we fix the weights of the network A and use network A as a feature encoder. Then all the image slabs in the volumetric CT images are processed by network A and then sent to network B to produce patient level PE prediction. Network B is then trained by comparing the prediction with the patient level PE labels. Our pixel level annotations were labeled by radiologists every 10 mm from CT volumetric images. And our goal here is to utilize those pixel level annotations to train an image encoding network that focuses attention on PE. Recently, class activation map, also known as attention map, has been used to interpret the convolutional neural networks. The attention map can indicate the discriminate image regions used by the CNN to identify a particular class. Later, guided attention inference networks GAIN has been developed, which shows that attention maps can be supervised while training the network. We performed attention training on a ResNet 18 in stage 1. The input is a 2.5D image slab with 5 consecutive slices, and we have the annotation mask corresponding to the center image slice. While training the network, in addition to the classification laws based on the PE label of the input image slab, we also have the attention laws to enforce the attention maps to be consistent with the downsampled annotation masks. Here we provide more details. Because in our data, the images have a variety of slice thickness ranging from 0.5 to 5 mm. We first resample the images to have a consistent 2.5 mm slice thickness. And we sample more than 10,000 slabs of annotated pairs from more than 1,600 positive volumetric images. And we sampled the same amount of negative slabs randomly from around 600 negative volumetric images. And all the images were cropped to the center 384 by 384, with the values mapped to between 0 and 255. We use 80% of the data for training and the other 20% for validation. We trained the network for 100 epochs and saved the model with the highest validation accuracy. Here are the results on the validation side. We first show some example attention maps. As can be seen, the attention maps produced by the network with attention training are more localized and show strong agreement with the annotation mask produced by the radiologists. On the other hand, the attention maps produced by the network without attention training are widely distributed and most focus on the irrelevant regions where no PE is present. On the right side, we show the ROC curves on the validation side. The network trained with attention supervision clearly outperformed the one without attention training. Note that even without attention training, the network still obtained pretty good PE prediction accuracy on the validation side, most likely due to overfitting, even though the network's attention was clearly not focused on the PE regions. Moving next to stage 2. In stage 2, we are dealing with volumetric CT images. The images were first cropped to the center 384 by 384 with value mapping, same as stage 1. We then identify lung regions using a lung mask produced by our in-house lung segmentation method. The identified lung region were further resized to 200 slices. We then sample 50 image slabs from it. In the end, we're dealing with data with size 50 by 384 by 384 by 5. Once we have the 50 image slabs processed by the pre-trained ResNet, we need another network to generate the data and provide overall P prediction for an image volume. To account for spatial context between the image slabs in a volumetric image, we use a recurrent framework. Here we use a bidirectional convolutional LSTM to interpret and summarize the patterns among correlated samples. The LSTM modules were applied twice. Then an average pooling layer was used to integrate the features along the z-axis. At the end, a fully connected layer summarizes the results and provides PE prediction. Instead of using the classification results or the attached maps of the ResNet as input to the recurrent framework, we use the last convolutional layer after activation to provide complete information embedded in the feature maps. We also try to use the classification results and the attached maps from the ResNet as input to the recurrent network in stage 2, but the results are not nearly as good. Here we show some of the training parameters. In stage 2, we only need to use the classification loss, and here we use the binary cross-entropy loss. We chose the atom optimizer. We train our network for 50 epochs and save the model with the highest validation accuracy. In stage 2 training, the training data actually contains two parts. The first part is the more than 2,000 annotated studies that we use in stage 1, but here we only use them as labeled volumetric studies. In addition, we also have more than 8,000 labeled volumetric images, where more than 4,000 of them being positive studies and more than 4,000 of them being negative studies. Our testing data contains around 500 positive studies and more than 1,600 negative studies. We created 3 testing scenarios. In scenario 1, we use both attention loss and classification loss in stage 1. But in stage 2, we only use the limited data that we use in stage 1 to provide patient-level labels. In scenario 2, we only use the classification loss in stage 1, but not the attention loss. But in stage 2, we use the large amount of label data. In scenario 3, we use both the attention loss in stage 1 and the large amount of label data in stage 2. As can be seen, scenario 3 gave us the best results, which show that both attention supervision and the large amount of label data are important in improving the results. This also demonstrates the scalability of our pipeline. If we have more label data from another hospital, we can only fine-tune the stage 2 of the network using the new data. We also compared with the state-of-the-art algorithm PENet. In PENet, their training data was labeled on a slice level for the presence or absence of a PE. However, our data were annotated every 10 mm in stage 1, and we only used the patient-level label data in stage 2. Because of this inconsistency, we did not run PENet on our data, and we only showed their reported results on their dataset. We also implemented the 3D-CNN for comparison. The 3D-CNN model starts with the I3D model, which is the 3D-CNN pre-trained on video action recognition dataset, followed by convolutional LSTM networks. This network structure has demonstrated success in acute aortic syndrome detection. In our study, this model was trained only on our patient-level labeled PE data. Here we show the comparison results. For PENet, we included the results on both their internal and external test set. Although the sizes of the test sets were both around 200, and they were all from a single clinical set with a single imaging protocol. Our proposed method was tested on a much larger test set, which come from multiple clinical sets with mixed protocols, and we still obtained much better results. Here, mixed protocols mean that our data contains both contrast-enhanced chest CT and CT pulmonary angiograms. They have different dose levels and different image reconstruction kernels with different slice thickness, so our task is actually more challenging. Our proposed method was also compared with the 3D-CNN model and obtained better results. One benefit of the proposed framework is its ability to provide localized attention maps. Recall that the ResNet in stage 1 can output the attention maps for an image slab. By integrating the attention maps for each slab together, we can have a patient-level attention map that indicate possible PE lesions on the patient level. Here we show two examples. The first column is the contrast-enhanced CT images, and the second column is the corresponding attention maps. As can be seen, the highlighted attention focus regions can accurately identify the PE lesions, which could potentially serve as a quick and convenient tool to help radiologists localize PE lesions. Note that this PE localization information cannot be used for diagnostic purpose because of the potential false positives. Instead, they should only be used as references. There are several future directions regarding this work. First, currently in stage 1, we use ResNet 18 instead of any deeper network to balance between the performance and our GPU resources. Although using more efficient network structures, for example, DenseNet, can be explored in the future. And second, currently the weights for classification loss and attention loss in stage 1 are the same, although these weights can be further optimized in the future. Third, we can explore a fully end-to-end training, where the weights of the ResNet can also be updated while training with the patient-level label data, and hopefully that can bring in some improvements. To summarize, in this work, we presented a deep learning model to detect PE on volumetric contrast-enhanced CT scans using a two-stage hybrid training strategy. In stage 1, we showed that training with attention loss on pixel-level annotated data can improve the network's localization ability. And the second stage convolutional LSTM network can reduce false positives on patient-level prediction. Our evaluation involves the largest number of patient studies so far among all the research studies on automatic PE detection. We achieved state-of-the-art PE detection results while providing attention maps for radiologists as references. Our proposed methods can also be applied to other detection problems as well. Thank you for your attention, and I would like to take any questions.
Thank you very much, Liuyao Shi. That was a great talk. I believe we're getting some questions in the panel. If anybody else has any more questions, please add them to the question and answer section in Zoom. Maybe while we wait a minute to see if more questions come, I have just a small question. I noticed that in the work, that you downsampled the pixel level PE ground truth to 24 by 24 in size to kind of guide the attention map. Would you ever find that by downsampling, I believe it's by a factor of 16, that you would actually remove the pulmonary embolisms so that you would actually be using a blank slice or blank ground truth for that slice?
I think we avoid that in our implementation because when we downsample the ground truth annotations, it's going to be a floating number mask, right? But then we just binarize it without using any threshold. So basically, we are not discarding any PE mask, but we might, like the mask might look bigger than it actually is on the smaller scale, but it actually is still going to cover the actual PE regions. Because we are not trying to train the segmentation network, we are trying to train the attention network. So as long we believe that as long as the mask still covers the PE region, is still okay.
Okay.
Yeah. Thanks.
Yep. Okay. Thanks. Pierre-Marc, should I?
Yes,
there's
a question in the Q&A by Shiba that is asking if there's any patch generation included in the pre-processing.
In stage 1, we use slapped data, but we didn't generate any patches. We just only cropped the center 384 by 384 part, which includes the lung, but we didn't use any smaller patch generation. to answer the question.
Okay. And there was a question by Jose Dolce, which is, I don't know if you can read it. It's a little bit long, but he essentially says, do you think that adding an explicit attention mechanism to the architecture to recalibrate the features can achieve similar results than those obtained by directly optimizing the generated attention maps? So if I understand well, he's saying essentially if instead of trying to generate attention maps, you could use these attention maps to recalibrate your features.
I'm not sure I completely understand the question, but by meaning,
for example, you had an end-to-end system where the attention maps were directly used to multiply the feature maps, like attention mechanisms.
Like some attention layers.
Yes.
I think we tried something like that in the past, but it didn't give us better results. One of the reasons I think is because some of the PE regions are really small, but by just some self-attention layers, it might not still like capture the PE regions. So I'm thinking like definitely the attention training with some like PE mask can help with the network.
Okay, time is flying. Thank you for your question. Time is flying. I see other questions, but maybe people could eventually go at your poster session to ask.
Welcome to my poster session. I'll be happy to answer more questions.
Okay, the second paper is entitled Automated Modeling Using an Attention Model for Radiology Reports of MRI Scans, ALARM for short. It's a work by people from UK, and the video will be presented by David Wood, the first author of the paper.
Hi there. Well, thank you very much for joining me. My name is David Wood, and I'm very happy to be presenting our paper at MIDL this year, titled Automatic Labeling Using the Attention Model for Radiology Reports of MRI Scans, or ALARM. And this work's all about enabling researchers to label hospital-scale neuroradiology imaging datasets for deep learning applications by deriving image labels from free text radiology reports using natural language processing. Now, before I start, let me quickly acknowledge our wonderful team. In particular, I'd like to mention Jeremy Lynch, Sina Kafiabadi, Emily Guillaume, and Aisha Al-Busaidi, who lead our clinical team, as well as James Cole and Thomas Booth, who are the lab leaders and PIs of the project. Right, so I'll start with a quick background. Now, a rate-limiting step to the development of real-world clinical deep learning applications is the difficulty of actually obtaining sufficiently large labeled data sets for model training. Now, the trouble is that retrospective hospital imaging data is very rarely stored in a manner that's suitable for machine learning, i.e. with associated categorical labels. And assigning these labels requires considerable domain knowledge and experience. Now, even for expert neuroradiologists, manual labeling is an incredibly laborious task. In our experience, it takes clinicians up to half an hour per examination to label images into the sort of granular categories that you might actually want a downstream classifier to incorporate. For example, mass or acute stroke or vascular abnormality and so on. So you're going to be waiting probably a few years to generate data sets of even a few thousand labeled scans in this way. Now, a promising alternative approach is to, instead automate this task by instead deriving labels from radiology reports using natural language processing, and then to assign these labels to the corresponding scans without having to ever actually manually inspect each image. Now, of course, this assumes that radiology reports faithfully reflect the contents of images, and you can read about the extent to which that's true in our follow-up work, which I've linked in the bottom right here. But basically, it's a very attractive idea because it allows huge collections of archived images, in our case, over 100,000 MRI scans, to be labeled practically instantaneously once your model has been trained. Now, this isn't a particularly new idea, and in fact, NLP has been used in this way to label head CT datasets from radiology reports before using fairly basic NLP techniques like bag of words and n-gram models. But until now, there's been no demonstration of this for MRI data. And we put this down to the greater sort of complexity of MRI reports, which follows from the sort of superior soft tissue contrast of MRI as compared to CT, which allows a more detailed description of abnormalities. And to give you sort of some idea of this, given a couple of examples here of radiology reports from our data set. And there are a couple of things that you may notice. Firstly, you see the reports read almost like a play-by-play commentary, listing various abnormalities which aren't present. For example, in the top report, you see that, it says no focus of restricted diffusion is demonstrated to indicate an acute infarct. There's no mass, there's no evidence of vascular malformation, and so on. Now, the trouble with this is that, when you compare it to the bottom report, which does actually describe an abnormal examination, in this case, an acute infarct, you see that the language used to describe the presence of an abnormality is very similar to that used to rule it out, to describe its absence, which of course is very unhelpful for the perspective of NLP, and it means that classical approaches involving n-grams or word frequencies or even regular expressions are likely to fail. Now, it's also common to see normal reports, like the top report here, which mention the presence of various findings, which are then a few sentences later deemed ultimately to be clinically insignificant. And you also see abnormal reports, like the bottom one here, which refer only to disease progress relative to some previous study, without actually describing the underlying abnormality in any particular detail. So all this is basically to say that, you're going to have a pretty sophisticated language model in order to perform this labeling task. And, in addition, it's going to have to be trained on fairly small numbers of labeled reports, because of course, if you have to get a team of radiologists to sit down for a year and label tens of thousands of reports in order just to train a labeling model, then, you could argue that you really should have just got them to label the images directly, in that time. So what's our answer? Well, rather than training a model from scratch, we instead fine-tune and build upon BioBird, which is a transformer-based biomedical language model, which has been pre-trained on huge collections of text, totaling more than 20 billion words, including most of English Wikipedia, as well as all PubMed abstracts and full text articles. And by initializing our model with these pre-trained weights, we inherit a considerable degree of low-level language comprehension, meaning that far fewer labeled examples are actually necessary for training our particular classifier, which of course is exactly what we wanted. Now, for those who are unfamiliar with it, BioBird, straight out of the box, basically takes as its input a piece of text in the form of a list of integer word IDs, and it outputs contextualized embeddings or embedding vectors for each of these words. And there are several ways that you can use the output of transformer-based models like BioBird for classification. Now, you can use the classification token, unsurprisingly, known as the CLS token, which in some ways has been designed to be a good general vector representation of the entire text. Or you can use various aggregations of the individual word embeddings. For example, just summing them all together, like I show here, or perhaps taking the argmax and so on. But we found actually that incorporating an additional attention module, which we parameterize by a simple feed-forward neural network, which learns to weight the contribution of each word by its context-dependent importance, actually leads to improved classification accuracy and also provides the model with some interpretability, which I expand upon later. So our model takes this weighted sum of embeddings, which basically becomes the vectoral representation of the radiology report, and it's passed to a 3-layer classification network, which ultimately outputs the probability that the report is describing one or more of the various abnormality categories, which I'm about to discuss. And we train the whole network, so that's the classifier, the attention network, the custom attention aggregation network, as well as BioBird, end-to-end on the basis of binary cross-entropy loss between the model predictions and the report labels. So onto the data that we used. In order to train the model, we obviously, of course, needed a set of labeled reference standard reports. And for this, we obtained over 120,000 radiology reports, as well as the corresponding images. And this consisted of all adult MRI head examinations from King's College Hospital, London, which were performed over a 10-year period. And from this, we randomly selected 3,000 reports for labeling by our team of neuroradiologists. Of these, 1,000 reports were labeled for for the presence or absence of each of 5 clinically relevant categories of abnormality. So those were mass, vascular abnormality, damage, acute stroke, and FASICAS, small vessel disease. And in addition to this, 2,000 reports were labeled for the presence or absence of any abnormality. And this is as defined by our team, which worked hard over the course of 6 months to design an exhaustive list of abnormalities, which would be desirable for an automated triage system to capture. And we provide that list as an appendix in the paper as well. So how does the model do? Well, shown here are the results for the binary classification task. So that's to determine whether a given report describes a normal or an abnormal examination. And as you can see, the model does very well. It outperforms the various baselines, which you can read about in the paper. Now you may think that these high numbers, the model gets over 99% accurate, and same with the sensitivity and specificity. You may think these high numbers suggest, perhaps this is just a relatively straightforward task, but have a look at the bottom row, which gives the classification performance of a hospital doctor with 10 years of experience as a neurologist and stroke physician, and who we also trained over the course of 6 months to actually label radiology reports. And remember also that in a lot of countries, and in the UK included, it's actually part of the job of a neurologist to interpret radiology reports during face-to-face patient consultation. So, the fact that this physician scores relatively poorly and that our model considerably outperforms them is, we think is very encouraging indeed. As for the granular classification, here are the results, and you can see that as a comparison in this case, we've included the performance of a blinded neuroradiologist this time, who also labeled the same reports. And you can see again, basically, that the model performs very well, even on this more difficult task, which is very encouraging. And in fact, it's only slightly inferior to the neuroradiologist, and it's practically comparable in performance. So, on the basis of these very strong results, we're very confident that our model, ALARM, can assign binary as well as more granular categorical labels to radiology reports, with almost no loss of accuracy compared to having an expert human perform this task. However, an important question which we didn't actually explore in the current work is how does labeling examinations on the basis of reports, like we've done here, compare to actually manually inspecting the images? Like, this is the gold standard. And in the paper which I linked before, and in case you missed it, I'll provide it here again. So in our follow-up work, our team of neuroradiologists actually explore this question. They explore the agreement between reports and image findings. And hopefully you'll go and read it. But basically, we've found that reports can, generally speaking, be very accurately used to assign labels to images. So as such, we went ahead and labeled the remaining 115,000 images, which we had reports for, using ALARM. And this actually took less than half an hour to complete, which of course is overwhelmingly faster than what you'd get with manual image labeling. Right, so before finishing, I'd like to highlight 2 more features of our model. First is model interpretability, right? So in addition to improving the actual performance, the custom attention module, which I introduced previously, and which was introduced in fact to aggregate individual word embeddings, actually in addition provides a nice form of model interpretability. Of course, this is a little bit of a subtle subject, and we don't want to claim too much, but it's certainly encouraging. We think that the model is putting lots of weight on words which do seem to carry a lot of information. For example, in the abnormal report shown above, the expression "there is an acute cortical infarct" is given pretty strong weighting, as are the words remainder and normal, which seems about right. And this is the same for the normal study below, where the expression "normal intracranial appearances" seems to dominate, while the negations, which rule out infarction, also contribute quite strongly. Now, of course, this needs further study and was outside the scope of the present work, but it's possible that a mechanism of this kind could help engender confidence in the model predictions, especially for clinicians. And we think it's quite a nice feature. Now, finally, we found that once we'd actually labeled our 120,000 odd MRI scans using, or reports at least, and images using our binary classifier, that is, the classifier that tells you whether a report describes a normal or an abnormal examination. When we looked at the visualizations, the low-dimensional visualizations of the embeddings for all the reports which were predicted to be abnormal, we saw something interesting. We saw pathology-dependent clusters. Now, what I mean by this is that there were, for example, groups of embeddings which, when we checked the corresponding reports, all referred to the same underlying abnormality, for example, Alzheimer's disease or perhaps high-grade gliomas. So to exploit this, we made a web-based annotation tool, and we make this available online to other researchers, which allows us to lasso all the reports from a cluster and write their accession numbers, which are basically just the unique exam identifiers, to disk along with a particular, the particular label. So this allows a sort of form of semi-supervised learning, whereby you identify clusters visually, you inspect a handful of reports from the cluster to determine what the common pathology is. It's normally very straightforward. And then with the mouse, you loop around the cluster, and then that downloads the entire collection of those examinations locally, which we think is very nice. And to demonstrate this, I've shown an example here of a high-grade glioma data set generated in this way. Right, so in conclusion, we have introduced for the first time a dedicated neuroradiology report classifier, which can be used to assign labels to images for deep learning applications. And the classification performance of the model exceeds that of an experienced neurologist and is comparable to that of an experienced neuroradiologist, demonstrating, we think, the feasibility of our approach. And in this way, we've been able to label over 120,000 images in under half an hour, which of course is a considerable improvement on manual labeling. And with that, I thank you very much for watching, and I'll look forward to answering any questions that you may have. Cheers.
Thank you very much, David. That's a very impressive piece of work. We have a couple of questions in the Q&A. So, April, do you want to read
Sure.
some?
It seems like the two questions are a little bit related, and it's around the fact that the BioBERT was for example, could you speak to how the general language model and the biomedical text model are qualitatively different? Perhaps some insights into the relative importance of semantic syntax. And follow up to that was, even though that these kind of two texts are different, did you adjust for that in your model?
Firstly, can you hear me?
Yes.
Yes.
Okay, wonderful. Well, thanks everyone for watching. Well, as we say in the paper, we tried to keep the pre-processing steps identical to because there's a bunch of these transformer-based models that you can play with online, and they all sort of have the same pipeline. And so we wanted to keep it, consistent for everything that had gone before. So we do exactly what it takes the same input as BERT does, as BioBERT, as clinical BERT, and so on. And the question, of course, radiology reports are, of course they are syntactically and stylistically different, but that's why we fine tune, I guess. So we do very little in terms of actual string manipulation and pre-processing, and we just fine tune basically. And that's why you can see, when we freeze the model, to the weights that you get directly from BioBERT training on PubMed, that the performance is, it's good, but it's considerably worse.
Maybe I have one question. Your work is very text related, and that's fine. But often with reports, we have patient information like age, body mass index, and so on and so forth. How would you include those extra information? Would these extra information considered like extra words, or you would somehow include it somewhere else in the network?
Yeah, so I'm sort of more in charge of the machine learning side, and my Tom Booth, who's here, can answer. He's a neuroradiologist, and he can tell me where I'm going wrong. But basically, the reports are almost self-contained because, like, the age and so on, of course, you're right. But for something like, neurodegeneration, for instance, of course, in the report, it's spoken relative to the age. So it's only abnormal if it's more than you'd expect for that person's age, and that's reflected in the way that it's reported. They'll say something like in excess for a patient of this age. So I think things like that don't necessarily actually have to come into it for our purposes.
I have just one little quick question, and then I think we have to move on.
Yes.
If that's okay. Were you finished, Pierre-Marc?
Yeah, I was finished.
Okay, sorry about that. I just wanted to know, like, you've tested on a lot of cases, 120,000. What were the outliers, like the actual ones that failed? Did you actually look at any of the reports that, were not correctly classified? And what was the cause of the breakdown? It's probably a loaded question at the end of the session, but maybe.
No, that's okay. And I guess it shows that you haven't quite got around to reading it yet. Of course, we do put examples in of where it has failed, and a couple of examples. Because we take everything in such a raw form, we download 10 years worth of data, and we don't really want to have to go through and manually, work out which ones are eligible and which ones aren't, because that sort of defeats the point in some ways. Some sort of fringe cases do slip through, and so we had example reports that normally you keep a spinal examination and a head examination from the same patient. If it happened on the same day, ideally they would either be in different sections or generate separate reports. But every now and then the radiologist, it doesn't quite happen that way. So we had a couple of examples where, the patient had a perfectly normal brain, but an abnormal spine. And so, for our purposes, that had been marked as normal, but our classifier had, and you can tell from the attention weights what it's thinking. It's paying a lot of attention to things like the thinning of the spine, the narrowing of the canal, and so on. So it's thought it's an abnormal examination because it is an abnormal examination in a way, but it's not neurologically abnormal. So things like that can slip through that. So that's just one example.
Okay,
Great.
Thank you. Maybe we can move on to the last presentation, April.
Yep. I'm just going to pull it up here. Great. So the last talk in the oral session for today and for the conference is locating cephalometric X-ray landmarks with foveated pyramid attention. And the author is, I believe that's presenting it, is Logan Gilmore.
My name's Logan Gilmore, and I am going to be presenting locating cephalometric X-ray landmarks with foveated pyramid attention. So we're going to jump right into the problem here. This is a lateral cephalometric X-ray where we can see that there's these 19 landmarks have been labeled onto this image. They're used for diagnostic purposes for orthodontic surgeries and stuff like this, but we're just going to be focusing on finding the landmarks themselves. So this data set has 400 images in it, and it's been labeled by 2 different medical doctors. And we're going to see if we can learn how to label these landmarks. So one of the best existing methods uses 2 different scales of random forest regression using HAR features. And a more recent method is a convolutional approach, uses 2 scales of UNet. So this is already kind of suggesting a multi-resolution approach might work well. Makes sense because the images are 2,400 by 1935 pixels. So CNNs were originally inspired by human vision. Here's some historical approaches. But for big images, we sort of see how they're not exactly like human vision, because with a really large image, if you try and, like the size we're working with, if you try and put that directly into a convolutional neural network, a vanilla network, you're going to run out of memory. So the key difference between how current convolutional neural networks work and how mammalian vision works, that is the source of this problem, is that where convolutional neural networks sample uniformly from the image, Mammalian vision has been shown to have a roughly log polar sampling density that's centered on the fovea. So that's wherever your gaze is currently directed. So on this slide, you can see some examples of approaches that do log polar sampling or fovea-centered sampling of some kind. And this is a thing that you can actually apply a convolutional neural network to, even with this log polar mapping. But the problem is that this is no longer going to be translation invariant. You can imagine the actual images are very warped towards the center once they've been mapped out onto a pixel grid. This isn't a huge problem necessarily, except we should no longer really hope for our transfer learning to work since the domain is so different. So what we're going to do instead is use image pyramids. Image pyramids give us sort of both things at once. They give us the really high density sampling of the original image, and they give us a lower sampling level as you go higher and higher up into the pyramid. But wait, you say, that's more pixels, not less. Yeah, so typically because you're making the amount of pixels you have to process higher. Typically, they're only used at inference time, or some people, there's like feature pyramid networks that construct them incidentally along with the features. So anyway, what we're actually going to do is just throw most of those pixels away. We're going to take a 64 by 64 patch from each level of the pyramid centered on wherever we're currently focused. We're going to use some kind of iterative method to decide where to focus. But the notable thing here is that if we use a fixed number of iterations, then the problem scales with the log of the side length of the image rather than the square of the side length of the image, which is a huge improvement and makes much larger images possible. So here's the proposed method. Our goal here is we're trying to figure out where that ground truth red dot is in the figure on the slide. And so we're going to make a Gaussian pyramid from the image. And then we're going to take a column from the image pyramid centered on our initialization. Here we just have it as the center of the image. And we're going to try and predict where that red dot is. And so the CNN will process all these different levels of the pyramid. You'll see that at the top level, the lowest resolution, the red dot's inside of it. So we probably can have a good chance of knowing where the landmark is at that level. And by the time we get to the highest resolution, it's actually not currently in view. So that level probably won't contribute much to the process. So then we're going to take all of the outputs from these CNNs, we're going to put them together somehow, we're going to feed them into a neural network, and we're going to predict a location. So then now that we have this new predicted landmark location, then we're just going to iterate this process again. So we've got this gray predicted dot, and we're going to take a new column, the set of dashed gray patches, which you can now see is much closer to the ground truth landmark, the red dot we're trying to find. And then we're going to make a new prediction. Because more levels of the pyramid can actually see the red dot within the column of patches now, the glimpse, we should be able to make a better prediction. So then we just iterate this process 10 times and take whatever the final prediction is. So there's some existing literature out there that does something like this, specifically recurrent models of visual attention. Uses a similar column taken from what looks to be an image pyramid, and they use an iterative process, moving their focus point around the image. What they're doing is more complicated in some ways than what we're doing, because they're using a recurrent neural network that's taking into account past glimpses, backpropagating through time, all of that stuff. And an additional major difference is that they're directly processing those pixels with the recurrent neural network, whereas we're going to process these things with a convolutional neural network to hopefully be a little bit closer to human vision. Okay, so now we'll kind of break down the individual pieces of this process a little further. So the first thing is the creation of the image pyramid. It's a Gaussian pyramid. It's downsampled by a factor of 2 at each level. Again, the patches, the gray there, are 64 by 64 pixel patches. And there should be enough levels in the pyramid that the top level of the pyramid encapsulates basically the whole image. So it's sufficiently downsampled that 64 by 64 is enough to see the whole thing. So for a visualization of what this looks like to the CNN, you can have a look at this figure. The red point here is the lower incisor landmark, and you can see that near the landmark we have really high resolution. And then as we sample further and further from the landmark location, we can see that there's lower and lower resolution as we step up levels in the pyramid. Okay, so next we're gonna figure out what the CNN is gonna look like. So one of our inspirations was trident networks. specifically what they do for object detection is that they simultaneously process inputs at 3 different effective resolutions, though they use dilated convolutions rather than an image pyramid to do that. So our approach hopefully has a little bit less aliasing than this. And the way they do this is they just use the same kind of a CNN you would use for one level, and then they run 3 different instances in parallel, which is sort of equivalent to doing kind of a weight sharing. So our CNN is a ResNet 34. It's pre-trained on ImageNet. It's got the final 3 basic blocks removed, as well as the fully connected layer. And so this is going to remove a couple of downsamples. And then we also reduce the stride of the input layer, so that effectively removes another downsample. So for a 64 by 64 patch input now, the resulting activation is going to be 256 by 8 by 8 volume. So again, you can see there's 4 instances of the CNN in this figure. They all share weights, so it's really just showing that we're processing each patch in the column with the same CNN simultaneously via vectorization. The reason we're using these big activation volumes is so that we can take methods developed in the pose detection literature for regression of joints, like human joints in images. What they found there is that it's actually more accurate to reformulate the problem as predicting a heat map of most likely joint locations, and then taking the maximum valued pixel and treating that as your location within the original image, rather than just having a linear layer at the end of the convolutional network predict a coordinate. Particularly, we're interested in integral human pose regression, which reformulates that taking the maximum valued pixel in the heat map as instead taking the expectation of those values, which effectively reformulates it as a center of mass type calculation. This has a couple benefits. One, it's differentiable, which is going to be important. And additionally, it means that you can get away with quite a bit smaller heat maps because each pixel is sort of taken into account for that final regression calculation. So what we're trying to do, though, is a little bit more complicated because we have all these different levels of the pyramid that we want to treat as sort of one cohesive foveated image. So if we just do like an integral regression at each level of the pyramid and average them, we're not really allowing for the sort of rich relationship across scales that we would hope for in something a little bit more cohesive that really takes advantage of the representation we're building. So if you've ever seen a visualization of the activations of later layers of convolutional neural networks, you'll sort of see that they learn to find these fairly high-level features. You could kind of interpret the activations as a heat map. And so the insight here is, what if we regress the locations of these arbitrarily found intermediate features rather than the location of the landmark we're actually trying to regress, and then use these features, what we call spatialized features, to then combine all the different resolutions together and regress the actual landmark location. So you can see here we're taking this activation volume in, and the 2 little cutouts are sort of little pretend versions of what you might see inside of one of these activations. So one of the 8 by 8 little patches from this volume sort of shows a feature that's strongly localized by the convolutional neural network, and it has a location that we can point to here. So we can use integral regression to convert this 8 by 8 raw activation into a probability distribution via softmax, and then find the expected value of its activation. And so we can do this for each of the 256 8 by 8 activations, and then concatenate all of these locations of these features that we've found, that we've learned to find, into a big feature vector. You could also imagine, though, like if you see the second cutout there, where there's really not much activation at all, probably the feature it's expecting to see is not present, you would want some way for the network to be able to indicate this. So the reason that we've got 3 vectors instead of just a 2-dimensional coordinate is that the final value is the expectation of the raw activations. So you can kind of think of this as a softmax pool, because we're weighting the original raw activations by the resulting probability distribution we derive from them. So we're going to end up with an average of the activation weighted towards the highest activations. So the assumption that this kind of forces the ConvNet to deal with is that each of its activations then at its output represents a feature that can be kind of localized and described by its center of mass plus one number indicating how present that feature is. So we can kind of look at some visualizations of features that it learns overlaid on top of the image. So each quadrant here is a different feature. The red dot is the landmark, the cella. That's the landmark that we were learning to localize. So the first thing you can notice is that it's not just learning to localize the average position of the cella with every feature and sort of average them all together. It's sort of actually learning something more useful. So in the left-hand side there, you can see the top of the two rows of images. It's sort of learning to find this point kind of at the back of the teeth. And then in the lower row, it's learning to localize this point sort of tucked into the eye socket. On the right-hand side, we have a higher resolution patch. It's closer to the native image resolution. And one of them is sort of finding a blob that seems to fit to the cella there. But then the other is sort of finding some point on that contour. So you can kind of see that it learned how to find these useful points so that later on, once we feed this into the next part of the network, these small, like shrunk down 3 vectors describe something useful. Okay, so now we're just going to step back to the big picture. A quick note, we've been talking about 4 levels. That's what we've got in the slides here. Actually, in the implementation, there are 6 levels. It's just easier to fit 4 levels on the slide, makes a better diagram. So talking about 6 levels, we've got 6 sets of 256 3 vectors. And so we're going to take all of those things and we're going to flatten them into one great big 4,608 vector. And then we're going to push that through a standard multi-layer perceptron. So that MLP has all ReLU activations. It takes us to a 512 vector, then to 128 vector, and then finally to the 2 vector that is our estimated error. So note that it's not an absolute value. It's predicting an error from our current location to the estimated landmark location. So what you would hope is as this thing iterates, that error is going to get smaller and smaller until it sort of becomes a fixed point where it sort of says, I'm here, and it just predicts 0, 0 as the current offset to the landmark location. Also note again, there's no backpropagation through time. We just apply the same process over and over again, and we do backpropagation on each iteration. So for training, we train 1 network for each landmark, and we're taking the initial estimate for where the network is looking from a normal distribution centered on the training set landmark locations. Oh, and also we train the network with Atom. In terms of results, it seems to work really well. We're state of the art in all measurements, and we are very close to the inter-observer variability in most cases. Okay, and thanks everyone, and I look forward to taking your questions.
Hello?
Hi. There was a little glitch. Can you hear me?
Yeah, I can hear.
Okay, good. Thank you, Logan, for your presentation. I cannot see any question in the Q&A, but I have some questions. Okay. I guess the most obvious question is related to one sentence in your paper, which says, we train 1 network for each landmark for a total of 19 networks per run.
Yes.
Wouldn't it be possible to have some kind of, an integrated network, let's say with 1 backend with 19 different heads?
Yeah, actually, so it's something that basically time constraints didn't get figured out for the paper. Oh, okay. But we figured out a way to do this using Siamese network. So you can imagine, we'll say instead of learn to predict a specific network, what if we have a network that if we point it at somewhere in like a reference X-ray that we've decided is clear and works well.
Okay.
We could say, please predict where head A is. Like we're asking head B to predict where head A is in the current image. And so then we can point it at the different landmarks and then say, please predict where it is now. Please predict where it is now. And then just basically use the initializations as the actual landmarks themselves. But then there's also kind of this nice property where we can ask it to do, you can almost do some sort of like pre-training there where you can just predict like arbitrary positions interpolated from the different points and stuff too. So it opens up to you doing a little bit more of a semi-supervised method.
Okay, well, that's interesting.
Yeah.
One question in the Q&A just popped out. Let me read this. This is by Shiba. In pyramid attention model, you have tried 4 layers and 6 layers. What is the intuition for this?
So basically the intuition for the pyramid was just make it deep enough that as you get to the highest level of the pyramid, so like for those 2,400 by 1980 or whatever pixel, like the big X-rays we were using, we make it deep enough so that by the time you've downsampled by a factor of 2, 6 times, now that 2000 by 2000 image is about 64 by 64 pixels. So we should sort of expect that at some level of the pyramid, we have the entire image in our field of view. Like so even though, low levels of the pyramid, only gonna be able to see a small portion at a time, we can sort of say, we should be able to sort of, even if it's a very low resolution, get a general sense of where we are in the total image.
Okay, well, thank you for your answer. Our time is up. It's already 1:31. So this is pretty much the end of the session. I would like you to know that if you stay in this Zoom session, we will soon start the teasers of the posters. Otherwise, you can leave right away and go and have a chat with the authors in the poster sessions, which should be open right now, or if it's not open, it should be open in a minute or so. Well, that's pretty much it for us. April, are you there? Okay, I cannot hear you. So thank you everyone for being there at this session, and see you soon.
Thank you very much, everyone.
Yeah, oh, there you are.
There I am.
That's great.
Yeah, I'm back. Thank you.
Thank you. Bye,
Enjoy the
everyone.
poster, and maybe see you in a couple of those rooms.
Yeah, sure.
Ciao.
Bye.
Bye.
This is a teaser for our work on automatic PE diagnosis. PE is a pulmonary artery disease associated with high mortality, and proper diagnosis and immediate treatment is important. The challenges of PE diagnosis include substantial false positive findings and being time-consuming. Therefore, we aim to develop a deep learning-based CAD framework to detect PE with high accuracy. We propose a hybrid training framework with 2 stages. In stage 1, we utilize pixel-level annotations to train a feature encoder network with attention-supervised training. Then, in stage 2, we utilize a large number of patient-level labels to train a PE prediction network. Compared with the previous state-of-the-art methods, we achieved better results on a much larger and more challenging dataset. The proposed framework is also able to provide localized attention maps that indicate possible PE lesions, which could potentially help accelerate the diagnosis process. For more details, please refer to our presentation and paper.
Hello, my name is Darvin Yi, and here's a teaser for our work on training on annotations with multiple false negatives. Most datasets have pristine labels like what you're seeing here. But what would happen if we knocked out or censored half of our lesion annotations? Come to my poster and read our paper if you want to learn why this doesn't mean the death of a project. We got figures, we got histograms, we got mathy stuff. Come check out how to become robust to missing annotations and scale up your datasets.
Streamlining digital prognostic framework has many benefits and thus has been the object of much research attention. Our research proposes an assessment protocol for analyzing visual manifestation of 1920 cogain, which is a prognostic biomarker. We assess the presence, characterization, and reproducibility of the mutation biomarkers. To tackle such a limited, diverse, and unbalanced dataset, we propose a novel generative framework called FEED-GAN, which is Feature Disentanglement GAN, to assess the reproducibility of the biomarkers. Such a framework also doubles as an effective data augmentation tool. We demonstrate that we can detect, reproduce the unapparent visual biomarkers. Our results, such as one on the screen, show that the feature disentanglement with selective training and semi-deterministic sampling is quite effective in tackling many problems associated with limited yet highly diverse datasets.
Hi everyone, my name is Ashraf Esmnali. In our work understanding Alzheimer's disease structural connectivity through explainable AI, we use machine learning algorithms and machine learning interpretability and explainability in order to understand dementia. It's a new work perspective of using explainable AI instead of developing new complex algorithm. By training an adapted version of brain cell in over-constructed DY MRI tractography over MRI images from a dataset, we could achieve a very good performance of classification while fine-tuning the model's hyperparameters. Meanwhile, we use features visualization techniques and ablation analysis in order to interpret the model's prediction and classification for better understanding of responsible regions of dementia. Thank you.
Fast mitochondria detection for connectomics. In connectomics, we acquire high-res images of the brain. In these images, we are specifically interested in the dark circular structures that are mitochondria. Here highlighted in red with a variety of different shapes. As part of this work, we released 2 new training and benchmark datasets annotated by experts in a consensus-driven process. Then, we train a UNet with reduced complexity. We are able to decrease the number of parameters compared to Ronneberger's original method by 93% without losing detection performance. Our method is fast and accurate. We detect mitochondria in real time with over 15 megapixels per second. Our method yields a competitive IOU of 0.942. Code and data are openly available. Thank you.
Hello everyone, I am Mohammad Minhajul Haq, a PhD student from the University of Texas at Arlington. This is the teaser video of my MIDL 2020 full paper, which is Adversarial Domain Adaptation for Cell Segmentation. In this paper, we propose a cell segmentation network utilizing domain adaptation technique with the help of annotated dataset. At first, we propose unsupervised domain adaptation network, then we extend it to the semi-supervised domain adaptation. Here is the complete architecture in which there are 3 modules. In our experiment, we used 2 public datasets. And from this table, you can see that our method outperforms 2 baselines and it becomes very closer to the upper bound. Here is a visualization from our first experiment, and this is the conclusion. Thank you, and please have a look at our full presentation video.
In this work, we focus on cross-domain calcified plaque detection, given only have labeled lung contrast CT. The idea is to translate the image from contrast-enhanced CT to lung contrast CT and use the lung contrast CT plaque detector. We first train image translation model using current method. The calcified plaque is scrapped after image translation. To better preserve the plaque structure, we propose 2 solutions. First, extract small-size image patch. Second, constrain the image patch in local clusters by union of subspace model. Show the translated lung contrast images by our model. The small plaque structures are preserved much better. We also show the quantitative results on cross-domain plaque detection and segmentation using Mars-Car CNN. Our model shows consistent improvement compared to the baseline model. Thanks for everyone's time, and please come to our presentation.
Hello everybody, I am Xin Li. I'm excited to present our work, WISP, an automatic medical image interpretation system. Many existing methods use a coarse grid of image regions as the visual features to generate report directly, whereas our approach first predicts and localizes the disease as the semantic features, then followed by a report generation. To do this, our workflow first annotates an X-ray image by classifying and localizing the disease, and then generates the corresponding sentence to build up the entire report with an attentive LSTM. In this way, our system is capable of accurately annotating X-ray image and generating quality reports, which also provides visual support to help radiologists to make diagnoses. Thank you.
Hi all, I'm Raghav Mehta and I'm going to present our work on uncertainty evaluation metric for brain tumor segmentation in MIDL 2020. Automatic brain tumor segmentation is useful for a variety of clinical tasks, but usually these automatic methods make mistakes, which hinders their adaptation in a clinical setting. Uncertainty generation methods like Bayesian deep learning methods allow confidence in the model output to be conveyed. But how do we quantify this uncertainty such that it makes sense in a clinical setting? In this work, we try to answer this question by developing an uncertainty evaluation metric for brain tumor segmentation tasks. We use this metric for ranking methods in the last year's Pratt's quantification of uncertainty in brain tumor segmentation sub-challenge, and we are organizing the same this year. For more information about the evaluation metric, please come by our virtual poster session from 1:30 p.m. to 3 p.m. on Wednesday, 8th July.
This talk will explain the multi-organ segmentation method called multiple resolution residual network for the automatic segmentation of thoracic organs at risk from CT images. The MRN, which has been published previously by our group, has the capacity to simultaneously combine information from multiple feature streams computed at various image resolution levels through residual connections. We trained this approach on an internal dataset of patients with lung cancer for the segmentation of the left and right lungs, heart, esophagus, and spinal cord. Our method was then tested using a public dataset provided by the 2017 APM Thoracic Auto Segmentation Challenge. And the results show that our network outperformed the best performing methods from the APM Grand Challenge for the esophagus, as well as achieved comparable results for all other structures.
Hi everyone. Here's a brief overview of our work on artificial intelligence-assisted MRI screening for pediatric cancers. When children are born with genetic conditions of cancer predisposition, they are encouraged to follow a well-established annual whole-body MRI screening protocol. Unfortunately, analyzing these images is very difficult for radiologists, and naive machine learning methods, which have shown promise in many imaging problems, are infeasible due to data scarcity and class imbalance. To overcome these issues, we augment a set of real whole-body MRI images using 4 GAN architectures and reformulate the problem as anomaly detection. We show that the StyleGAN2 architecture generates more realistic images, and in our extended abstract, we demonstrate that domain Fréchet distance is a more appropriate metric than Fréchet inception distance when comparing the quality of generated images. Finally, we demonstrate a proof of concept of GAN-based anomaly detection methods, including ANOGAN, and show that using the discriminator as an anomaly detector outperforms the classical watershed method.
Making a difference to billions of lives is the aspiration of the healthcare intelligence team. I love doing research with a view towards having both technical as well as societal impact, especially in healthcare, where the potential for impact is very exciting. At Microsoft Research, I get to spend 100% of my time doing exactly that. Thanks to big healthcare data, there's a huge opportunity for AI to revolutionize healthcare.
At Imagia, we gather creative minds to reimagine healthcare and reveal the full picture of personalized health. By creating a collaborative ecosystem of the best clinicians and AI scientists, we are able to tackle some of the biggest challenges in healthcare today.
At CFAR, we see research differently. It's about more than proximity and disciplines. It's about asking the big questions and assembling the right teams to find answers, being bold and taking risks, supporting diverse researchers who achieve unprecedented advances in life and health, for individuals and society, for Earth and space, for information and matter, for the world. We support the risk takers. We enable big thinking. We bring together the brightest and boldest minds across academic disciplines and across borders to address science and humanity's most important questions. Together, we stay curious, and we will continue to provide researchers with the time and freedom to explore new ideas. As we look to the future, we will work from this premise. Fundamental research matters. Some of it changes what we know about the world today, and some of it will change what we know centuries from now. All of it fuels innovation and advances humankind. Join us.
Ismail.
Hi, hello. We're still seeing people entering the room, so we'll wait a few minutes to see people in. And thanks again for sticking around for the next, for the last, very last session. All right, I guess we can start the very last session of this year's MIDL edition. So my name is Hervé Lombard, and on behalf, in fact, of the whole team, including the session chairs, Chris, Maxime, and us, the program chairs, Marlene, Tal, myself, and Ismail, and the whole other team as well, the whole team as well. So we wanted to give you a thank you as well in the whole conference. This whole conference has been running online, which is interesting to do. And because of that, we have a huge, absolutely huge thanks to give to our virtual arrangement chair. We call him the magician who makes the whole thing works behind the scene. He works actually a lot. You've been noticing a lot of his work as well. So a huge thumbs up to Hoel. Tess as well has been working a lot as well behind the scene, making sure everything is synchronized, communicating on Twitter. So apparently there's a lot of activity on Twitter, the chat. So everything runs smoothly because of the online parts, because of Hoel and Tess. So they deserve a huge round of applause as well. So this year's MIDL 2020, just to give you an idea on how much work it is and how much fun it is actually. So MIDL 2020 is as well, for example, 2,495 emails internally, all sent among us. I counted earlier 83 hours of calendar events, so that's quite a lot. We had to organize a whole conference in Montreal. So the local team they have rented the whole Congress, Palais des Congrès and all. So all that was super great, hotels and all. Then something happened. So we had to face one pandemic and redo everything. So that was a challenge of this year, which is interesting. The good thing though, we were able to run this year's free edition. So that's perfect. That's really, really great. that opened up, and that's why I wanted to mention this, that opened up to much more registrants. And we see this among the last 3 days. A lot of participants online, on YouTube as well. There's a live stream if you haven't noticed. So that's perfect for that. So the countries of papers that you guys have all submitted are marked here. However, what is really interesting, because of this online edition, that's the map of all the views from the YouTube live. So YouTube provides a few statistics on who clicks, who watches things. So dark countries, dark color means people. The darker it is, basically, the more viewer here. So we see the usual countries from the authors, but you also see a lot of other countries. I'm thinking, for example, Nepal, South Africa, even Nigeria here. All those countries. I mean, honestly, personally, I feel it's the online access has made things. I mean, the rich, like more people could see this conference even for free. So that's a very positive thing from this year's edition. So I'm on behalf of the whole team, we are super happy because of that. Below is a few statistics as well on attendance. Where are you all from? So mostly North America, but then Europe, and then a lot of countries which I feel could, like, basically the openness of the conference goes even beyond with this online access. So that's perfect. I think it goes totally in the spirit of MIDL. So that's there's more statistics as well, and because we wanted to thank Joel as well, so that's and he's more aware. He's really dealing with all the numbers and all. So that's he's the best person to talk briefly on these numbers here.
Okay, thanks, Hervé. So we don't have yet all the statistics about the chat and the webinars, but what we have already seen on YouTube is that twice the amount of people watch the stream on the first day and on the second day, and there is a lot of views for our videos, recorded talks coming from all across the world. We can see, that there's a peak in view in North America, but still a lot of people are watching it depending on the time zone. And we are quite curious to see how it will continue in the coming days and weeks, because the conference won't end right now. You can keep watching the videos, you can keep going on the chat, which will stay online. So we are quite curious to see the impact of this new format and how long people will keep interacting.
All right, yeah, so that's a few statistics. There's much more we can start to analyze and all, but we just wanted to provide you a few numbers. As Joel was mentioning, it's, I mean, this is a very particular conference, so that's why it's worth mentioning here. And beyond statistics and all, we have to acknowledge the whole team. I mean, it's not only the science part, but it's a lot of there's the reviews, area chairs, handling all the whole submissions that you guys have answered, submitted. Open review, as we mentioned in the opening as well. It goes totally with the spirit of the conference as well. We have a bunch of other people to thank: the open review team, session chairs, of course, the keynotes. There's a good award committee who worked hard on finding the best papers and the best reviewers as well. Challenge committee, you'll see the conference is not finished, it's still running tomorrow. We'll talk about this a little bit later. Diversity inclusion, so far no problem reported, but of course do report if you have any issues and all. That's very important. Industrial liaison, that's what made the whole thing possible as well. We have a good list of good sponsors as well. Mentorship, this year's edition we've been running mentorship, so that's apparently a good thing to do. And of course the local volunteers behind the scene as well. We haven't talked much, but it's a lot of volunteers did check all your videos, PDFs and all. So that's we have to thank them of course. And the most important one is of course you all included in your living room or in your wherever you are. And so because of your work and sharing your work and sharing your knowledge, so that's you have to be thanked first. Sponsors, again, all this is possible because of them. So that's important to mention as well. Proceedings, that's worth mentioning because all your work, including mostly the full papers, those are published in Proceedings of Machine Learning Research, and it already has a volume number, so you can start citing them accordingly, correctly on a CV with the right volume number and all. Short papers, we tried as of the last years as well to gather all the short papers in an archive compendium. So at least it gives you something more official than simply a link on the website. So that's good. And on top of that as well, we will send you will receive an email in the chat as well. You have more information on a survey. Because of this particular year, we have a few questions on what you liked, what you should do, and so on. And like we'll run a survey on having your feedback is very important. Interactivity is a crucial part of MIDL. One thing to mention as well, there's behind the scene again, there's a RSIP journal, has been running an article on this year's edition of MIDL. So that's worth having a look. It will be out. It's already online. It will be out in the August edition. So that's good to be seen that like this way. It's a very good journal as well. They have different conferences. They cover different conferences and all. A few photos still worth playing around. There's some bloopers or all. We all remember the clapping of Matthias. So that's good to do. Now it's hard to reproduce the same thing as Matthias. Great talks, great science as well. A lot of tweet activities. So that was a surprise, more than we thought. So that's good as well. Great keynotes, great motivation, great messages to newcomers, people entering the field, starting the field as well. A lot of good things, including I don't know, including sexy red curtains as well. So that's fun as well. Almost there because the conference is still not finished, as I was mentioning. It's tomorrow's running challenges, and because of that, we're passing over the microphone, let's say, to Pierre-Marc, who is
Yes, so tomorrow is challenge day. There's going to be 3 challenges. So details on the content of the challenges and the ways of getting in touch with the organizers and to join the Zoom sessions is on the challenge website, and the link to the challenge website is on the MIDL website. So if you go on the MIDL website, look for challenges, you'll find it right away. One thing I would like to add on top of that is that, next slide, is the challenge committee, which was made of Annika Renke. I don't know if Annika is online, but you did a terrific job. So a big thank you to Joseph Paul, who have been very active in reviewing the challenge proposals, and a big thanks to Maxime, who has been there right from the beginning. So one thing I would like to add is that all 3 challenges went through the tightest evaluation protocol we could find. And that the goal was to match a recommendation made in that paper. This is a Nature Communication paper that was published 2 years ago, which reviewed 150 different challenges that occurred in the last 10, 12 years, and came with some clear list of recommendation of what challenges should contain in the future. So the 3 challenge had to, respect a series of criteria. I'm not going to list it all, but just to give you a short idea, all of these challenges now have a very, very clear description of the challenge, as well as the data description protocol. They all have a very clear ethic approval section on their website. The evaluation software, as well as the ranking method, which was not always clear in the past, now has been made crystal clear. The data, as well as the ground truth of the data, the website, as well as the evaluation system, were up and running right from day one. It was back in February. So that challenges had access right away to the data. The annotation protocol was also very tightly looked at. The organizers were strongly encouraged to release publicly some basic software toolbox, to allow challenges to easily load the data, process it, get some meaningful results. And all of the challenge proposal needed to have a clear statement on, is it still possible to beat state-of-the-art results in their area? Because we didn't want to have, you know, a challenge where all of the challenges end up underperforming with respect to state-of-the-arts. So all of this, and et cetera, et cetera. So there was a very long list of criteria. Based on that, I believe that the challenges that will occur tomorrow are of very great quality, and I hope it's going to be like this again in the future. So back to you, Hervé.
All right, so thanks. Yeah, again, tomorrow challenges, still not finished. We have an important word as well from the MIDL board. So this is the entity that covers the whole MIDL. So that's, I'm passing over the microphone, let's say, to Ivana.
Thank you. My name is Ivana Ishkun. Can you please go to the next slide? So on behalf of the MIDL board, I would like to thank everyone for the fantastic organization of the conference. As was already said, this was supposed to be an on-site event in Montreal, and only a couple of months ago, the plans had to change and the organization had to be switched to full virtual event. And we were a bit nervous given the very short time to the conference, but the organization was absolutely outstanding. So the board wants to thank again conference chairs, Christopher and Maxime, program chairs, Marlene, Tal, Hervé, and Ismail. Thanks to Joel for virtual arrangements and Joseph, Tess, and Margot for local arrangements. I cannot name everyone here, but we really want to thank again everyone who has participated in the organization of the conference. We are also very pleased, happy that sponsors provided the support that allowed free registration, which allowed broad participation, as Hervé already showed. I'm sure that many students who could not have attended conference otherwise now had the possibility to attend. Can you please go to the next slide? So in the past year, we have set up a MIDL Foundation. So it is a non-profit legal entity that has a task of organizing yearly MIDL conferences. And the establishment of this foundation enables easier financial organization of the conferences. I think I have...
Sorry, I screwed up.
Okay. Can I have the slide back? But okay, for everyone who is interested, there's information about the MIDL Foundation and about the articles of the foundation on the MIDL.io website. And when talking about the organization of the yearly conferences, we are looking forward to the MIDL 2021 in Lubeck. We'll come to that shortly. But what I would also like to add that we were planning to have a call for organization of the MIDL in 2022 already published on the website, and normally we would have done part of the selection process in Montreal, but because of the corona crisis, this was postponed. The uncertainty about the virtual event, on-site event, and possibly hybrid conference setup. So what we would like to do now is evaluate this virtual event and then make a decision. So please, again, fill in your evaluation forms, provide us feedback on the organization. We will look at that and then decide how the conference we would like to see in 2022. And the call will be published on the MIDL website shortly. Thank you. And again, thanks to everyone who has participated and organized this conference.
Excellent. Yeah, thanks, Ivana. And now we're passing over we're passing over the responsibilities to Floris, and so that's the next year, part of the next year's organization as well. So go ahead.
Thank you very much for the kind words, Hervé and Ivana, and my apologies for being too eager to share my screen. So for interrupting your presentation, I'm really sorry about that. Anyway, I personally also want to thank everybody in Montreal for the really great job they have done in hosting this virtual conference. It was really amazing, and I'm just fascinated how you set this all up in this short amount of time, and I'm really, really happy that we could participate there. Anyway, we're all still hoping, and so please keep your fingers crossed that we can host you in person in Lübeck next year. This is the view of the historic city center of Lübeck, as you are hopefully be able to see it from the Congress Center, where we'll be hosting the conference next year. And it will take place in a really great historic event setting. The Hanseatic city of Lübeck is more than 1,400 years old and features a UNESCO World Heritage flair, as you can see here on one of those sunny days that we've been having in the past week. So I'm really hoping that's going to be like this next year as well. And all the venues and all the places that will be part of the conference are within walking distance or even part of this historic city center. Lübeck's Congress Hall is just across the river from the city center. So you're looking at more or less the view that you're going to have from the outside of the conference center, or through the big glass windows of the conference center even. And I'm really looking forward to welcoming you there. And you can see an impression on the bottom right of the conference center and the interior of this really amazing location with special and world-class acoustics. And Matthias is going to talk a little bit about the planned scientific program at this point.
Thanks, Rose. And let me also extend my gratitude to this year's organizers, including Joel and Tess, who did such a fantastic job at organizing a virtual MIDL in such a smooth way. We, of course, hope to have as much real-life interaction as possible, but are planning ahead to have at least the possibility to stream all the content and remotely present your work. And after some discussion with the MIDL board and other conference organizers from next year, we decided to put the submission deadline for the full papers right in the middle between IPMI notification and earlier than MICI submissions. But we also want you to have the opportunity to present and submit your very latest work. So the short paper deadline will be much later in mid-April 2021. So that you have the chance to show your latest results. Aside from hopefully very great scientific program, we are planning a number of exciting social events, including a gala dinner in St. Mary's Church, which has the largest brick wall in the world. And as you may know, Travemünde, a suburb of Lübeck, is just directly at the Baltic Sea and has some really beautiful sand beaches. And Lübeck is therefore also one of the few places where you can easily arrive to the conference by ferry. Based on the great success of this year's mentor program, we're planning a fully fledged doctoral symposium where we will have some invited talks from established academics, but also the opportunity for you PhD students to interact amongst each other in social events, sharing your work, which might not have been able to present at the main conference, and have really an extra day set aside for doctoral students. And ideally, and we're pretty sure this is going to happen for free. So with this, I'd like to pass back to Floris.
Yes, thank you. And to be able to make it free, of course, we will be relying on sponsors, and I hope that we will be able to attract a couple of companies, just as you have been able to do this in Montreal so far. So if somebody's listening and has a couple of spare euros, please don't hesitate to get in touch. We'll be very happily taking them, and would be very, very nice if we could bring down real life conference registration fees very much, or if the conference has to happen virtually, which we all do not hope, but it of course could happen, that we will be able to make it free again, depending on the amount of sponsorship money that we will be able to acquire. So you have seen myself and Matthias. We are part of this 4-person organization team in Lübeck and Hamburg, and we omitted this so far. This is not just something that's going to be organized by the University of Lübeck, but the Technical University in Hamburg will also be part of this. This is our neighboring city, and so you'll see the other 2 people involved, Alexander Schläfer and Jan Lellmann, who will be part of the committee who set up middle 2021. And we're really looking forward to seeing you all in person if possible, otherwise via Zoom, WebEx, or whichever sharing system we'll be using next year. And we're really, really happy for the great conference that we had this year. And so this is the end of the presentation, and I thank you all for participating.
Yeah, let's try to all open up our cameras, no, and see and say hello or something, no. All right. Yeah. Wow. Excellent. So we feel less alone in our kitchen or our offices or whatever. Yeah. Bye.
Bye, everybody.
Bye, everybody.
Bye.
Thank you.
See you next year.
Yeah.
That was great. Thanks.